statements on enhancing governance, leadership, and HR for health. And then second, being comments or questions from the rest of the participants. And now I invite member states with an interest or intention to deliver statements to indicate. Zimbabwe, Uganda, Tanzania. Okay. We'll start with Zimbabwe.
Thank you, Honorable Chair. Good morning to you all. Excellencies, Honorable Ministers, distinguished colleagues and partners, an equitable and well-distributed health workforce is the backbone of universal health coverage. No health system can deliver quality, accessible care without sufficient numbers of skilled, motivated, and appropriately deployed health workers. For our region, addressing health workforce gaps is therefore both a national and a collective priority. Zimbabwe has placed human resources for health at the center of its health system reforms. On 17 October 2024, we signed a landmark Human Resources for Health Investment Compact, committing to double our health workforce by 2030. Since then, implementation has moved decisively from policy to action. Already, the production of health workers, particularly nurses, has exceeded annual projections, reflecting expanded training capacity and stronger alignment between training institutions and service needs. At the same time, establishment expansion is well on course. In 2025 alone, an additional 5,284 health worker posts were availed across the system, with further expansion planned for 2026 and beyond. This scale-up is critical to sustaining service delivery and accelerating progress towards universal health coverage. Equally important is where health workers are deployed. Zimbabwe is prioritizing equitable distribution with deliberate incentives for service in underserved, hard-to-reach, and rural areas. These include targeted recruitment, rural allowances, improved accommodation, and career progression pathways. Our goal is clear. No community should be left behind due to the absence of skilled health personnel. Excellencies, health workforce development does not stop at national borders. Cross-border training and regional collaboration are essential to building specialist capacity and retaining skills within Africa. Zimbabwe has long benefited from and contributed to regional training synergies. We have hosted trainees from neighboring countries, while our own citizens have undertaken advanced training in countries such as Zambia and South Africa. While Zimbabwe has a strong foundation in undergraduate and postgraduate clinical training, anchored in robust hands-on exposure, many subspecialist competencies, including cardiothoracic and hepatobiliary surgery, cardiology, and nephrology, have been developed through regional partnerships, particularly with South Africa. These collaborations have strengthened our referral systems and reduced reliance on costly external care. We also strongly commend the ECSA specialist fellowship programs, which have introduced a more flexible and innovative model of training that allows specialists to train without relocating from their home countries. This approach is accelerating skills development, improving retention, and directly strengthening service delivery, bringing us closer to universal health coverage. In conclusion, Zimbabwe believes that Achieving an equitable health workforce requires sustained investment, deliberate distribution strategies, and strong regional cooperation. By harnessing cross-border training and expanding our workforce at scale, we are laying the foundation for resilient, people-centered health systems across ECSA region. I thank you.
Thank you, Zimbabwe. Next is Tanzania.
Thank you, Chair. On behalf of head of the delegation, may I present the Tanzanian statement. The United Republic of Tanzania aligns itself with the statement delivered on behalf of the African region, and they appreciate the Secretariat in the East and Central and Southern Africa Health Community for the comprehensive background on the strengthening governance, leadership, and human resource for health as the foundations of the resilient and people-centered health system. Chairperson, resilient health systems are fundamental to achieving universal health coverage, safeguarding health security, and sustaining socio-economic development. Recent global and regional challenges have reaffirmed their resilience is built on strong leadership, effective governance, sustainable financing, and a capable health workforce, particularly at the primary healthcare level, where services are delivered closer to the community. Significant progress has been made in strengthening governance and leadership across the health system, enabling improvements across all building blocks. Enhanced stewardship has improved policy coherence, service delivery, health information systems, transparency and efficiency in financing and accessing to essential medicines and health technologies. These reforms have also strengthened multi-sectoral coordination in line with the health in all policies approach, ensuring that health considerations are integrated beyond the health sector. At the primary healthcare level, strengthened governance has resulted in more responsive, accountable, and efficient services. Health facility governing committees have been empowered to oversee planning, budgeting, and performance, enhancing community ownership and accountability. Structured community engagement has increased the trust, improved service utilization, and supported the continuity of care, particularly for maternal, newborn child, and adolescent health services. Human resource for health remain central to the delivery of quality services, especially with the expansion of universal health insurance. Improvements in the workforce planning, training, deployment, and supervision have strengthened the service readiness at facility and community levels. A motivated and competent health workforce is essential to ensuring that financial protection translates into real access and improved health outcomes. Honorable Chairperson, investment in community health workers have strengthened the promotive, preventive, and basic curative services at community level. Through the integrated and connected community health programs, community health workers have been trained and integrated into formal health system with clear governance, supervision, and a referral mechanism. Their contribution to the health promotions, early detections, follow-up of insured clients, and community-based surveillance have enhanced the services delivery and emergency preparedness. Tanzania highlights the persistent regional shortages in the health workforce density across all cadres. While regional training initiatives have yielded positive results, gaps against WHO benchmarks remain significant. Sustained investment in training, recruitment, retention, and equitable distribution of health workers supported by regional collaborations remain critical. In conclusion, United Republic of Tanzania reaffirms its commitment to strengthening governance, leadership, and human resource for health through strong partnership at all levels, to continue support for the implementation of the ECSA Health Community Strategic Plan 2024-2034, and sustained collaboration will be essential to strengthening primary health care and secure, resilience, people-centered health system for present and future generations. Thank you very much. Siyabonga.
Thank you, Tanzania. Asante sana. Next will be Malawi.
Chair, Excellencies, distinguished delegates, I am honored today to contribute to the dialogue on enhancing governance, leadership, and human resources for health. Malawi fully aligns with the objectives of the session and commends ECSA-CHS for its support in strengthening health systems through localized specialist training and regional standardization of care. A persistent challenge in Malawi and the region is the shortage of health workers at all levels, compounded by skills gaps, uneven distribution, limited leadership capacity, and migration of critical cadres. In response, Malawi has implemented several best practices to strengthen health system performance. Localized workplace-based training for nurses, midwives, clinicians, and specialist cadres has improved retention and service delivery. Leadership and management capacity has been enhanced through mentorship, supportive supervision, and development programs, improving accountability and team performance. Partner-supported health workers are being absorbed into the government payroll and deployed more equitably, ensuring training investments expand access to underserved populations. Regional collaboration through ECSA remains essential. Harmonized training standards, mutual recognition of qualifications, sharing best practices, and addressing health worker mobility collectively are critical to sustaining gains. Malawi reaffirms its commitment to strengthening governance, leadership, and human resources for health through sustained investment, political leadership, and regional solidarity. Together, we can build a capable, motivated, and well-governed health workforce that delivers quality care and advanced universal health coverage across the region. Malawi further recognizes and appreciates the role that ECSA is providing in training specialists in various fields. The training is affordable, relevant to the disease burden in the region, and retention of specialists is very good. Malawi, therefore, fully support the college. Thank you.
Thank you, Malawi. Next is Uganda.
Uganda applauds the role of ECSA in training the human resource, which we believe is the most important resource that we have on our continent. We know that right now, our most important area of focus is to ensuring that the quality is taken care of, not just the quantity of the human resource. And this, we have prioritized it in National Development Plan to increase the recruitment by 20,000 workers, but not just the numbers, but to ensure that the quality is also paid attention to. The regulatory framework in our region needs to be strengthened so that we standardize the curriculum, we standardize how we monitor the training, and we standardize the licensing. Chair, we also think that ECSA needs to prioritize to expand the skills that they are training in the colleges. As we see that medicine is not static, more disciplines are coming on, more threats are coming on. We need to see more, for example, health informatics. We need to see more skilled in high robotic, high technology, AI-driven technologies be trained in our curriculum so that people meet the current standards. Lastly, Chair, I cannot leave this without mentioning that as we concentrate on the human resource, we need to be cognizant that when you have human resource, you must create an environment to retain, to foster proper working environment so that the human resource stay and work and they are supported by not only skilling, but also providing the equipment that is required. So as we talk about human resource, we need to improve on the equipping and ensuring that they're enabled. Lastly, Chair, we also do believe that as our carers are giving care, we do not have sufficient programs for care of the carers. Who takes care of the carers? You'll find they have mental health issues, they have so many challenges, but we need to emphasize, we need to foster an environment that supports the carers. Thank you very much.
Thank you, thank you, thank you. Thank you. Sorry for that. Thank you, Uganda. I underlined proper working environment and care of carers. You can't pour from an empty vessel. Thank you, Uganda. Next and last is Eswatini.
Thank you, Honorable Chairperson, Honorable Ministers, distinguished delegates. Eswatini believes that universal health coverage and health security will only be achieved if our health workers have the right skills mix, are in adequate numbers, and are supported by through strong stewardship and by accountable institutions. This is what we aspire to achieve within our health sector in Eswatini. Guided by Eswatini's health workforce strategy of 2025 to 2030, we are focusing on 5 priorities: better alignment of human resources for health investments across government and partners, expanding employment to accelerate service coverage, strengthening education and training, improving management to support equitable distribution and retention of health workers, and strengthening governance and coordination of the workforce. As part of strengthening the local healthcare workers' education and training, Eswatini has established its first medicine training school in one of our universities. The country has also made progress in scaling up workplace-based fellowship and specialist training in 2 accredited health facilities. This includes postgraduate fellowship trainings in general surgery through the College of Surgeons of East, Central, and Southern Africa,
Sorry for that. There's some maintenance work going on the main grid, but we've since switched to generator. Please do expect some disturbances until whatever they're trying to rectify it is rectified. Eswatini, please go ahead.
Thank you, Honorable Chair. May I start with the paragraph that was in the middle? As part of strengthening local healthcare workers' education and training, Eswatini has established its first medicine training school in one of our universities. The country has also made progress in scaling up workplace-based fellowships and specialist training for doctors in 2 accredited health facilities. This includes postgraduate fellowship trainings in general surgery through the College of Surgeons of East, Central, and Southern Africa, COSEXA, and the College of Anesthesiologists of East, Central, and Southern Africa, CANEXA, and has so far graduated 2 doctors in anesthesiology in 2025. ECSA-COG fellowship and ECSA-CON trainings are in the pipeline for doctors and nurses, respectively. This approach strengthens capacity of regional hospitals, reduces avoidable referrals, and builds teams on the job. It also reduces reliance on training abroad, thereby helping to mitigate the brain drain. In line with strengthening governance and coordination of the workforce, our ministry has been mandated by the Health Act of 2023 to establish a Health Service Commission with the objective of streamlining the recruitment, training, and fair distribution of healthcare workers to ensure equity in service delivery in the country. Eswatini will continue working with ECSA, College of Health Sciences, higher education authorities, and professional councils in our member states to harmonize competencies, strengthen leadership in curricula, and accelerate implementation of resolutions and decisions taken in such forums. I thank you, Chair.
Thank you. Sorry for that. Sorry for that. I will now invite comments or questions from the rest of the participants. Please indicate if you have an interest to make a comment or to ask a question. Okay. We have only WHO Afro and UNFPA. Please, WHO Afro, go ahead.
Thank you very much, Conference Chair, and we really welcome the statements that have been made by the member states on this topical issue. I really would like to reinforce two major points. And in 2024, WHO and member states endorsed the WHO Charter. And really, I think moving forward, those 5 principles should guide our planning. I can recall some of them: issues around governance, leadership, and stewardship, evidence-based prioritization, and especially looking at staffing norms and standards, and then alignment and synergy across investments and partnerships, and then fostering sustainability. So I really think as we move the workforce agenda forward, we really need to be reminded about that workforce charter. Secondly, the WHO Global Strategy on Human Resources for Health 2030 emphasizes the importance of partnerships. And I really think that in the current financial landscape, Africa CDC has its own plan, WHO has, World Bank is supporting countries. We need to synergize and be able to support member states to develop strategies. The critical piece in those workforce strategies is really conducting health labor market analysis. Several countries have been supported by WHO to do that. And the evidence from that really is helping to see where there are gaps, where there are challenges, areas where there are distribution issues. And the second point I want to raise is information, because the charter says we need evidence-based information. If you look at DHIS2, we're looking at health outcomes, but we don't track health workforce data very, very well. And I know Kenya, for example, has really done a more integration of their health workforce data for HIV forward, and it has really helped improve how we plan for the health workforce. Finally, retention, and Uganda has raised this. I think we need innovative initiatives for retention. We have been working with countries, and the World Bank is also working with countries to look at what are the better innovative strategies for us to retain health workers. Some of them are benefits packages, good working environment, and sometimes school fees benefits. We really need to think out of the box. Like our regional director actually has often said, maybe we don't need a box. We don't need a box, so we don't need to think outside. We need to remove the box and start thinking openly. I thank you very much.
Thank you, WHO Afro. Next is UNFPA. Arches, you are the last one. Thank you, Dr. Okelo. Thank you so much for your contributions. We should definitely use this platform for networking. And that marks the end of session 7. Thank you. Please let us quickly move to, that marks the end of session 6. Let us quickly move to session 7 before the sabotage. We will move straight to session 7, progress in responding to communicable diseases and NTDs in ECSA region. We have WHO to make a presentation on sustainability of financing of NTDs and malaria elimination programs. Focus on MOUs of cross-border collaboration. WHO, please. Let's encourage him with a round of applause.
Conference Chair and Director General, ECSA, distinguished delegates, ladies and gentlemen. My name is Ambrose Talisuna, and with the liaison office in Addis Ababa. And I'm making this presentation on behalf of my colleague, Maria Polo Robelo, with the Global Technical Lead for Prevention and Chemotherapy for Neglected Tropical Diseases and Malaria. NTDs are definitely a big burden, and if you look, there are over 21 conditions, from helminths, protozoa, viruses, ectoparasites, those due to toxins, and a couple of you who have been seeing the media, some music guru from Nigeria died of a snake bite. So you can see, so they don't even respect showbiz. But they are diseases mainly of poverty. The multidimensional burden of these, approximately 1 billion people affected globally. 1.4 billion require NTD interventions, 2024 data. 120 deaths, 14 million disability adjusted life years lost. Loss of productivity, catastrophic out-of-pocket expenditure, reduced education and professional attainment. A psychological burden also for some of them because they disfigure. What are the targets? We wanted to reduce by 2030 by 90% We are just doing dismally. We are at 32%. So in 2023. So on NTDs, we are really not doing very well in the burden. I have some slides which are a bit crowded, but I'll not go through all of them. In terms of increasing the number of countries that have at least one NTD eliminated, 100 by 2030, we are at 58, just slightly over 50%. I mean, those of you who mark anyway, if you are close to 60%, yes, maybe, but in medicine that is not, it's not a distinction actually, so this is just pass credit. So we are not doing very well. Funding, there is a funding decline. And even if you look at malaria, for example, if you look at the most recent malaria data, but if you look at across NTDs, the funding, especially from official development assistance, has been declining over the period 2018-2022. So, external financing is reducing. We need to be looking at how do we manage financing moving forward. And that's really, you can see for the years, and across a range of different funding partners, top 10 top funding related projects. Now, there are a couple of challenges that we see with NTD and malaria elimination. Insufficient funding, despite the availability of the Global Fund. You know, the Global Fund came in 2002. It has funded malaria, TB, and HIV. A couple of people said these global initiatives verticalized programs, probably yes. Later on, they started including health systems. I used to sit on the Global Fund Technical Review panel and would look at whether proposals had a health system component. If they were not, we rejected them. So there were some benefits in later years. Inadequate and often irregular country ownership, suboptimal inclusion of NTDs in strategic and development plans, uneven commitment, decreasing capacity and expertise. And sometimes, you know, when you move towards, in the failed global malaria eradication program, actually what happened was that we failed to eradicate malaria, but then we had also eradicated entomologists. So we had again to recreate them because we failed to eradicate the disease, but we eradicated the experts. So we need to be careful when we have some of these targets that fail, because you lose the experts and then the disease has remained. But for some of diseases, they are really what I call threats. And one of them for malaria is really the biological threat. At the moment, we really have a threat of parasite resistance to the only drug that we have, artemisinin-based combination therapy. We also have mosquito resistance to the insecticides that we use for indoor residual spraying, but also for insecticide-treated nets. But we also have another challenge, which is parasites that are developing. They get a deletion in one of the genes for some of the diagnostic tests that we use, especially the rapid diagnostic tests. And you end up not detecting the parasite, so you get false negative results because the parasite has deleted that gene. And increasing role of urban malaria transmission in some areas. So it started off in the Horn of Africa, but we are seeing this now. There is more urban malaria transmission, and we need more to rethink. But inadequate health systems, climate change, and the creating vectors in areas where we didn't have them, of course, epidemics. And epidemics disrupt health systems, and they disrupt routine services, whether they are NTDs, communicable diseases, or mental health and psychosocial support. But there are some opportunities. I think with this funding decline and health ministers who are here, we really need, we have been discussing here, increasing domestic financing. And that domestic financing should not only be budget support. We should get more domestic financing from other sources. And my friend Ogo is here. I don't want to start risking talking about financing when she's here. She might say I've messed up. We need to diversify external funding. We need a more engagement of the academia. And I'll really, in terms of the R&D for new products. There are neglected tropical diseases. We don't have treatments, we don't have diagnostics, we don't have vaccines, and we really need to be churning that in the R&D agenda. And we need more collaboration with different institutions, ECSA, colleges of practitioners, a key one there, and also innovative information and strengthening community systems. So, in terms of integrating the programs, I think in today's challenging financing landscape, we need to integrate. We need to integrate. I'll not go through all those. We need to redesign the system to ensure we have sustainability in the delivery of NTD services through a comprehensive intervention and transformation of how we plan, finance, and deliver healthcare services. That one, we need system transformation, break down silos. We're having several silos, and I think we need to break these down. We need prevention and curative services across the continuum, and also integration of fundamental, needs a structural change. There are some basic issues around on integration and sustainability that we need to be delivering. For example, I need to see these, my eyes are not. Integration really contributes directly to achieving of the Sustainable Development Goals. But also, there are issues that we should address for the beneficiaries, for the providers, and for the decision makers. So, my colleagues have raised some of the principles that we need, some of the key domains around integration in terms of multi-sectoral approaches, but I will not go through some of these. I can't see very well. Leadership and governance. You know, old age is catching up with me. Monitoring and accountability is a very, very critical one. And monitoring and accountability for me is a real critical one that we need. I will not go through the principles of integration, but these are in the slides and you can look at it in the interest of time. And also some of the issues around system achievement. Now, these are really for ECSA-HC countries. I thank you very much. Asante sana. Ziko mokwambili.
Thank you, Uganda. I've concluded that Ugandans are naturally funny and happy people. And soon I will organize a trip to Uganda. I now invite member states to indicate their intention to deliver statements. Tanzania. I've always wondered what the N stands for in entities. Now I understand. They are indeed neglected. Okay, better. We'll start with Tanzania.
Thank you, Honorable Chair, Ministers, Head of Delegations, the ECSA and partners. On behalf of the Head of Delegation, just allow me to deliver the statement of the United Republic of Tanzania. Honorable Chair, the United Republic of Tanzania recognizes that communicable diseases like malaria and NTDs remain significant public health threats that demand resilient and sustainable financed health systems. As we align with the 2030 elimination targets, our focus must shift from emergency response to sustainable and integrated programming. Chairperson, Tanzania remains committed to the Abuja Declaration goals of allocating 15% of the government budget to health. However, with regional spending often below recommended levels and the high dependence on external funding, accounting for nearly 45% of health spending in several ECSA states, the sustainability of NTD and the malaria programs is at risk. To counter this and to sustain gains that have been achieved for many years, Tanzania is now prioritizing domestic resource mobilization through innovative health financing mechanisms to reduce donor dependence. We are also strengthening our health systems with a focus on primary health care as a primary vehicle for delivering integrated, scientifically proven in prevention and the control of malaria and NTD interventions, but we are ensuring equity and value for money for every shilling that we spend on. Enhancing and integrated approaches for malaria and NTD digital data management into the national systems to improve accountability and resource allocation. Honorable Chair, the critical role of cross-border collaboration as diseases know no borders is important. Tanzania's progress in elimination is inseparably linked to the status of our neighbors. Fragmented health data and uncoordinated response across borders continue to undermine regional resilience. Therefore, Tanzania strongly advocates for formalized MOUs for cross-border collaboration, and we call for finalization and implementation of robust memorandum of understandings between neighboring states supported by WHO headquarters and AFRO. These MOUs must facilitate joint surveillance, synchronized mass drug administration, and shared planning. Chairperson, sustainable elimination is only possible if we secure our borders through solidarity and secure our budgets through domestic commitment. Tanzania reaffirms its commitment to work with ECSA, health community, and WHO to establish these vital cross-border MOUs, ensuring that our collective health gains are protected for future generations. Honorable Chair, I submit. Thank you. Asanteni sana. Siyabonga kakulu.
Thank you, Tanzania. Next is Eswatini.
Thank you, Honorable Chair. Excellencies, distinguished delegates, Eswatini is encouraged by the steady progress against major communicable diseases and neglected tropical diseases. These gains are driven by strong political leadership, strengthened primary health care, and practical regional collaboration. With regards to HIV, Eswatini was among the first countries to achieve the UNAIDS 95-95-95 targets ahead of schedule through high testing coverage, rapid treatment initiation, and sustained retention so that people on ART achieve and maintain viral suppression. We are expanding combination prevention, including 6-monthly long-acting injectable PrEP, lenacapavir, and advancing towards validation of triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis. TB and HIV collaboration remains strong through routine screening, prevention, and coordinated care. Honorable Chair, with regards to TB, the incidence has declined by 51% from about 7,400 people falling ill in 2015 to an estimated of 4,000 in 2024, and TB mortality fell by 60% in 2024 compared with 2015. We are intensifying facility and community-based case finding and scaling key innovations, including rapid molecular testing for all people with presumptive TB, digital chest X-rays with computer-aided detection and genomic sequencing for improved detection of drug-resistant TB. We are expanding TB prevention therapy, implementing shorter, safer regimens for drug-resistant TB, and decentralizing care through community-centered models. Treatment success for the last cohort evaluated stands at 83% for drug-susceptible TB and 86% for drug-resistant TB. Eswatini remains very low endemic for malaria and is progressing towards elimination. By strengthening surveillance, vector control, and case management, while deepening cross-border collaborations with neighboring countries to reduce imported cases. Honorable Chair, concerning the neglected tropical diseases, NTDs, preliminary impact assessment findings are encouraging. Schistosomiasis prevalence has declined from 15.7% in 2015 to 6.1%, and soil-transmitted helminthiasis from 5.7% to about 1.5%. We are advancing towards certification for elimination of diseases such as leprosy, while strengthening prevention and care for rabies, scabies, snake bites, and other priority NTDs through integrated national and community platforms. Sustaining gains will require continued partnerships and increased domestic investment. I thank you, Chair. Siyabonga.
Thank you. Thank you, Eswatini. Next is Uganda.
Chair, neglected diseases are the diseases of the poor. And whatever we do to deal with neglected tropical diseases, we need to deal with the poverty. If we eliminate poverty, we shall eliminate neglected tropical diseases. Why? Neglected tropical diseases are neglected. And because they are neglected, they do not get the attention they deserve. In our country, although we have eliminated some, but some continue to cause morbidities to our population. One sure thing we know is that the oocytes of schistosomiasis will not know the border. It will flow in River Kagera and go to Tanzania. And therefore, they will get the schistosomiasis. The earlier we collaborate, and I just want to emphasize the message of the presenter earlier, the earlier we get harmonized approach to tropical diseases, neglected tropical diseases, the better. Why are we still talking about neglected tropical diseases in Africa? Because we do not have a dedicated funds for research and development. Malaria has resisted to only one medicine we have. Apparently, Chair, other people are going to the moon. We are here suffering with malaria. And nobody is investing in research and development for the resistance that we are seeing. When we got COVID, within 2 months, we had a vaccine for COVID. Why? Because the developed countries were equally affected. Malaria is for the poor, and it is our burden. The earlier we developed research and development in our institutions and find a solution for our own problem, the better. Lastly, mosquitoes have no passports. They will cross. If we have harmonized elimination strategies in the region, it will be better. If Uganda has elimination strategy and Tanzania has a different elimination strategy, will not be able to move at the same pace. Therefore, Uganda stands to agree with the presentation that we need to harmonize our elimination strategies. We need to integrate our services because we do not have enough resources. And we need to be intentional in developing solutions, research and development. We have herbal medicines, but we are not investing in research and development to address our own problems. Thank you very much.
Thank you, Uganda. Next is Malawi.
Thank you, Chair. Your Excellencies, distinguished delegates, Malawi has made significant progress in controlling communicable diseases, while recognizing that sustaining these gains requires continued investment, resilient systems, and regional collaboration. The country faces recurrent public health threats, including cholera, mpox, polio, and climate-related shocks, which strain the health system and disrupt service delivery, highlighting the need for strong preparedness, timely response, and long-term resilience. The Ministry of Health and Sanitation, with partners, has strengthened preparedness and response through the Nation Action Plan for Health Security, guided by the One Health approach. Emergency coordination has been improved via the National Public Health Emergency Operations Center in high-risk districts, enabling timely information sharing, evidence-based decision-making, and efficient resource deployment. Strengthening the health workforce remains central. Initiatives such as field epidemiology, training program, emergency medical teams, and community-based surveillance have enhanced the skills of responders and volunteers, improving early detection and response. The Health Emergency Preparedness Response and Resilience Program further strengthens surveillance, laboratory systems, and multi-sectoral collaboration. Malawi has achieved the HIV 95-95-95 target and continues to integrate HIV, TB, malaria, and neglected tropical disease services into primary care and community platforms. Key lessons include the importance of integrated service delivery, resilient supply chains, and regional collaboration. Through political commitment, evidence-based strategies, and cross-border cooperation, Malawi is building a stronger, equitable, and resilient health system, capable of sustaining gains, advancing disease elimination, and achieving universal health coverage. As for malaria, it remains endemic with climate variability, requiring strengthened case detection, laboratory capacity, and uninterrupted access to diagnostics and medication. We need to find a sustainable way, or rather ways, to eliminate malaria. Thank you.
Thank you. Thank you, Malawi. Minister, you're looking good. Yeah.
Thank you, thank you.
Up next is Zambia.
Thank you, Chairperson. I will deliver a statement on behalf of the delegation leader. Zambia has made measurable progress in responding to communicable and neglected tropical diseases through structured national plans and targeted intervention through significant system challenges. Though significant systematic challenges persist, Zambia is endemic for 16 years of the 20 NTDs listed by the World HOW, with the lymphatic filrosis alone affecting 96 districts. The country efforts are guided by two key frameworks: the National Health Strategic Plan for 2022 to 2026, which aims to strengthen the overall health system, and the dedicated NTD Master Plan 2022 to 2026, which provides the integrated roadmap for controlling and epidemic NTDs. A cornerstone of this work has been the Mass Drug Administration campaign for lymphatic fillosis, running since 2014 and achieving coverage rates of 92 across epidemic districts. This success has placed Zambia in the surveillance phase of LT elimination, where transmission assessment surveys are conducted to validate progress. For acute outbreaks, such as the cholera cases reported in early 2026, responses have involved rapid deployment of SAGE staff and RCCE via CBV diagnosis and treatment, and strengthens water, sanitation and hygiene wash measures, oral cholera vaccination campaigns. Communicable diseases like HIV, tuberculosis, and malaria continue to be leading causes of mobility, even amidst a decline in new HIV infection. The health system itself, while with a focus of development, faces constraints such as workforce shortages, with a goal to increase staffing from 48% to 70% of establishment and infrastructure gaps that affect consistent service delivery. Chronic challenges include the threat of climate change, altering disease transmission patterns, persistent stigma around conditions like LF, and the need to better integrate care for issues such as snake bite enveloping into primary health service. Critically, a 2026 study highlighting the progress remains vulnerable to fluctuations in international development aid, noting that past funding cuts have historically reversed gains in similar countries. To explore particular aspects of this situation in greater depth, one could consider several focused areas. These include the implementation and challenges of mobility management and disability prevention, services for chronic NDSs, how climate variability is specifically affecting the epidemiology of malaria and LF in Zambia, and the role of community-based strategies improving drug distribution during MDA campaigns, while simultaneously working to reduce stigma. Chairperson, I thank you.
Thank you, Zambia. Thank you, member states, for your statements and sticking to the allocated 3 minutes. Next, I will invite comments, questions from the floor. Please. Questions? Contributions? Yes.
Infectious diseases are the burden of...
Just a minute. Dr. Shiva. Please go ahead.
Thank you, Mr. Chair. First, maybe I might make a comment. Mr. Chair, you hold the spear as well as you hold the shield. And I pay homage to the legacy of my old friend and colleague, Dr. Simon Konene, and I could see it. One of the greatest fighters for malaria elimination in SADC as well as in Africa. And I could see that his legacy lives on in the Kingdom of Eswatini and in the Ministry of Health of Eswatini. My comment again is public health and public health medicine, primary health care, health system strengthening are the most cornerstone of successful, sustainable, resilient national health services and systems. Now, I go back to also the legacy of Dr. Malik Ibrahim Samba, WHO Regional Director for Africa, who started after the OAU Harare Declaration on Malaria, the Rollback Malaria and the Global Malaria Elimination Program, because all the ministers of health of SADC requested that WHO should start a major campaign against malaria in Africa. The successful Global Malaria Elimination Program or Eradication Program of WHO eradicated malaria from the United States, North America, and many Central and Southern America, and was centered in the Centers for Disease Control, which today is being requested to reform by the US government itself. And also many parts of Asia, Japan, Korea, Central Asia, and today we also have successive elimination of malaria in Algeria, Cape Verde, Egypt, and we were very close in Eswatini, South Africa, Botswana, Zimbabwe, Namibia, but it has resurged again. So my request is again that ECSA College of Public Health Physicians plus other colleges are available to support a coordinated effort of SADC, ECSA, WHO, and Africa CDC to tackle the burden of infectious diseases in Southern Africa as well as rest of Africa. But we can start here in Eswatini and ECSA countries. And we also need to learn from the successful examples of malaria elimination today in Indonesia, China, as well as India, and reorganize and re-reflect our techniques in South-South cooperation. Thank you.
Thank you, Dr. Shiva. And thank you for recognizing Simon Nene, better known in Eswatini as Mbuzulwane, mosquito. Yeah. Next is ECSACON.
Thank you.
ECSACON, please also touch on coordinated efforts.
Thank you, Chair. And thank you to the presenter. I just want to talk to the NTDs. I remember when we were in Malawi in February, we talked about the neglected tropical diseases. And the question that came from that discussion was that these diseases are neglected by who? We still do not have a question, but an answer. But from the response from the Minister of Uganda, who said NTDs are diseases of the poor, I stand to believe, Honorable Chair, to say what WHO has presented there, to say we need to have MOAs as countries in how we are going to tackle the NTDs. let, of course, WHO again guide us in naming the tropical diseases, not to say neglected, because once we say neglected, they will be neglected even in our plans. So WHO should come up with the proper name and remove the neglected, so that when you go to WHO, you go to WHO with a position to say Africa has recommended that for neglected, quote, in quotes, tropical diseases. In Africa, we want them to be neglected tropical diseases so that we have them in our plans. And when we implement, we are sure that they are taken care of. I thank you, Chair. I said, oh no, well done. Well done.
Thank you, Hexacon. Next is Alma. Dr. Pumapi, go ahead.
Thank you, Excellency. And I would like to echo my brother's recognition of the valiant work that Dr. Kunene did with his colleagues, and congratulate you, Honorable Minister, for your commitment to malaria elimination and the commitment of His Majesty. It is my conviction that Eswatini can eliminate malaria before 2030. You are almost there, and I just want to thank you and your commitment. I also wanted to thank Eswatini for leading by example. When His Majesty was the chair of ALMA, he set up an End Malaria Council and Fund. And this is an exemplary partner to the Ministry of Health. And it brings together the private sector, public sector, leaders, other sectoral ministries, religious organizations, the church, traditional leaders, and together as a community, you have taken on the responsibility of eliminating malaria, and this is the way to go. And you are using a digital management tools to monitor progress using real-time data. So you are actually accelerating the strengthening of the health management information systems. And I would really like to encourage all our countries to set this up. In Zambia, they have all the technical partners as a technical committee that supports the council. And this works extremely well. And I believe that by starting with malaria as an example, we can include diseases that ministries need to eliminate, working across sectors. Malaria and neglected tropical diseases, for example, are not only the burden of the Ministry of Health, they're also the burden of the Ministry of Environment, Agriculture. So if we work together with a council and a coordinating committee of experts that can guide the work of the council, and digital tools that will assist with the monitoring, identifying of bottlenecks, we have a structured way of actually doing this systematically. And I believe it can be done. I agree with ministers, distinguished speakers who have said neglected tropical diseases are actually being neglected by us Africans. So we need to prioritize them. And we don't need to become rich to eliminate neglected tropical diseases. Togo has demonstrated that they've already eliminated 4. Guinea worm, elephantiasis, sleeping sickness, trachoma are fully eliminated in Togo. And they did this through political commitment first, and then mass drug administration and the work of community health workers. So it is not rocket science. I also just wanted to say one of the threats or big challenges that are driving the spread of mosquitoes, and I thank WHO for the various threats that they enumerated. One of them is population growth on the continent. So we must accept that we do need to get resources from outside government and expand the fiscal space because our population has grown. In 2000, we're 831 million. Now we are 1.58 billion. This is the population growth on the continent. So we have more people to protect. And it is necessary for us to work across government, across sectors, and expand the fiscal space. Otherwise, we would not be able to do this. I also want to thank the Zambia, which is currently working with us to actually look at ways that you can expand the fiscal space. And we have brought in leading African health economists, experts, who are going to be working with the Zambian government, and I want to thank them for that, and looking at expanding the fiscal space and having a sustainable health financing mechanism, not just for malaria, neglected tropical diseases, communicable diseases, but for all of health across the board, an integrated approach. And Zambia is planning to have a webinar the end of this month or the beginning of September, of March, I beg your pardon, to share with other countries. And I really invite countries to participate in this. I know some of you are working on it, but you can also share your experiences and share best practices. I just wanted to clarify one small thing about artemisinin resistance. The comment was made by WHO, but I'm a board member of MMV, Medicines for Malaria Venture. And last year, we actually completed phase 3 trials, working with African countries, including Tanzania, where we are headquartered, and where we have been able to develop a non-artemisinin-based combination treatment, which is a combination of ganaplacide and lumefantrine. And the stage 3 trials actually showed 97.4% correction rate for uncomplicated Plasmodium falciparum malaria. So we are very confident that we will have another alternative on the table this year that will be able to fight against this resistance. And I want to thank the African countries where the trials were conducted. Thank you, Mr. Chair.
Thank you, Alma, and thank you all for your contributions. But before we move on to the next session, I'll allow the DG to comment, especially on coordinated efforts.
Thank you very much. I think there was a comment from the ECSA regarding coordination. So the ECSA health community, we are taking that. And that's why we're working now with the WHO Afro, AUDA NEPAT, and Africa CDC, and trying to establish the coordination framework under the South-South Cooperation. But we are also working with the College of Public Health Physicians to be part and parcel of this conversation. So, Honorable Chair, in that area of coordination, I think with the regional approach, we shall be able to address so many challenges that we have had in the past. Maybe to add on what Joy Pumafia has commented on, indeed now there is a substantial evidence that there is artemisinin resistance. So we will be working with Alma to continue advocating for the switch, because for now the switch is inevitable if we are to win the war against malaria. So a part of that, we are also working with the Novartis, which is a big pharma based in the Basel, Switzerland, to start now the advocacy across our member states on the resistance that has been noticed, and now have been a lot of publications around that area. Last but not least, it was on the comment that was given by Dr. Shiva. Primary health care is a strategic area where we can do all the investments, because the studies and the science has shown us that that is an area which is quite very cost effective. If you want to get on the return on investment, you need to invest at the primary health care. But also, if you want to achieve universal coverage, which most of the African countries are lagging behind, we are below 50 in terms of the UHC service coverage index, while the global average is at 68. We really need to continue investing at the primary health care. And going back again, as the last point, in terms of neglected tropical diseases. Neglected is going to be prioritized if we do not harness the system thinking. But if you have a system thinking approach, the word neglected disappears. Why should you prioritize one disease over the other while your thinking is beyond those 6 building blocks? So having only 6 building blocks without thinking of the commercial determinants, political determinants, the global health initiative determinants, and the socioeconomic determinants, then you find yourself now saying, this lymphatic filariasis, trachomas is neglected. So we need to change the way we think and the way we approach the implementation of these interventions. In so doing, then we will find ourselves, we have eliminated all these diseases, so-called neglected tropical diseases. I submit, Chair.
Thank you, DG, and thank you everyone for a wonderful session. Partnerships have always been a cornerstone of the East, Central, and Southern Africa's efforts to improve health outcomes across the region. And now we're going to jump straight to session 9. Because some of the panelists are leaving in an hour's time. So without wasting time, let me kindly invite Dr. Silumesi to start the proceedings of the first panel discussion. Thank you.
Thank you very much, Honorable Chair. Partnerships have always been a cornerstone of the East Central and Southern Africa health community. And in our efforts to improve health outcomes, we recognize partnerships as being very pivotal. And therefore, this session on fostering partnerships is aimed at engaging various stakeholders that we work with in supporting the implementation of the Regional Health Agenda, as well as ECSA's Strategic Plan 2024 to 2034. The ECSA Strategic Plan is the region's collective vision for addressing critical health challenges, health system challenges, and promoting equitable access to quality health care. Therefore, this session will provide a platform for our partners to identify the opportunities that exist to support ECSA's vision, but more broadly, the Regional Health Agenda. With that said, ladies and gentlemen, I have the rare honor and privilege to introduce our distinguished speakers for the panel. To start with, I would like to call upon Dr. Ahmed Ogwell, who is the CEO and President of Village Reach. Dr. Ahmed. Secondly, I would like to call upon Beth Ward, who is the Strategic Lead, Workforce Capacity Building in the Commonwealth Pharmacists Association. She's based in the UK. Thirdly, I would like to call again to the platform Dr. Ambrose Talisuna, who is the Senior Health Advisor with WHO, and he happens to be the WHO liaison officer to the AU and to UNECA. And last but not the least, I would like to call upon Mr. Seth Nimwesiga, a public health lawyer working with the Center for Health, Human Rights and Development based in Uganda. Ladies and gentlemen, you are very welcome to this panel discussion. We have 30 minutes very strictly, and we will attempt to keep to our time. I would like to start by requesting each one of you to briefly talk about your organization. Who are you? What do you do? Dr. Ahmed, Village Reach, what is in the name Village Reach? Please tell us about Village Reach, what you do, and where you work.
Thank you, moderator, and thank you very much, Chair, for the flexibility. Village Reach is 25 years old. We were, yes, I'm a little younger than that. We were founded by Her Excellency Mama Gracia Machel and another colleague, a Cameroonian American called Serge Blasio, during the 2000 very heavy flooding in Mozambique. That's where the story began, and there was a very large area of Mozambique that was affected, and Mama Gracia's immediate concern was how do vaccines get to the areas that have been flooded. So out of that, and Serge was working for a telecommunications company in Seattle. Out of that collaboration, Village Reach was born initially to ensure that vaccines were reaching each and every part of Mozambique, and that's where the work started. Today we work in 20 African countries, including for the ECSA region, Malawi, we are in Kenya, we are in Tanzania, and other countries across the continent. What we do today is strengthening primary healthcare systems. And we work with governments to ensure that the primary healthcare system is actually functioning. It is everything from designing it to the supply chain aspect where we get products to the communities, and then we get information and lab samples back to the center. It is in ensuring that the operational side of things are well handled, including immunization and addressing zero-dose children in the communities. It is in advocacy, so that models that are working can be able to be scaled and where appropriate adapted. Also finally, it is in ensuring that countries utilize that result to improve other parts of the health system. I must also add that we are not only in Africa, the 20 countries, we also work in the US, in the northwestern side, and we also work in Pakistan. So we have a very broad reach globally when it comes to primary health care that is responsive.
Thank you very much, Dr. Ahmed. We'll move on to you, Beth. We know that you've been with us during the pre-meeting with the pharmacists. Let's start from there, your impressions, and then you tell us a bit about the Commonwealth Pharmacists Association.
No, thank you very much, Moderator and Chair, for the opportunity to speak today. So yes, we were part of the AMR pre-conference to really look and see how the pharmacist workforce has been involved and continues to be involved, and the opportunities for it to be involved to strengthen AMS priorities and deliver on AMR national action plans across the ECSA region. So by way of introduction to the Commonwealth Pharmacists Association, we were established in 1969 under the premise that the Commonwealth network should be harnessed to share resources, pool expertise, and ensure that standards are raised across the board with no country being left behind. And so we are a charity, we're an accredited organisation of the Commonwealth and in special relations with the World Health Organisation. Our goal is to advance equitable access to high-quality medicines and pharmaceutical services for a healthier world. And we do this by working very closely with the national pharmacy associations across the 56 countries of the Commonwealth and beyond, many of which are in the ECSA region here. And we work also with ministries of health, governments, regulators and other institutions in country to support strengthening health systems. We're very practical focused. For us, it's all about taking those policy commitments and supporting countries to translate that into implementation on the ground. And our areas of focus and expertise really are in workforce development, antimicrobial stewardship, which is why we were here for the conference, strengthening primary health systems and non-communicable diseases, but importantly also supply chain and access to medicines, which we've heard here time and time again across the last few days, but globally is a considerable problem.
Well, thank you very much. Thank you, Beth. Dr. Talisona, I know everyone in here knows WHO, but maybe sometimes we take it for granted that everyone knows what you do and what you stand for. But let's give you the opportunity of just speaking again to that, your role in this space of public health and promoting partnerships.
Thank you very much, the moderator and colleagues. Yes, we've been around for some time, since 1948, so 77 years old. And as WHO, really, our role is we are the directing, coordinating authority on international health. We provide leadership on global health matters, shape the health and research agenda, set health norms and standards, articulate evidence-based policies and options, and also we provide technical support to countries and monitor and assess the trend of health events. Now, in this mandate, of course, around post-Ebola in West Africa now on the continent, we got Africa CDC, which has also got the same mandate from the African Union. So the liaison office was then set up in Addis Ababa because Addis is really becoming a center for setting continental policy. So at the liaison office, we try to ensure alignment, complementarity of what WHO is developing as policies and strategies with those health policies of the African Union and its organs. And a couple of the organs are Africa CDC, for example, the African Medicines Agency, the Humanitarian Agency, which is going to be set up in Kampala, Uganda. Auda NEPAD has been around here. But also, we then look on the other side with the United Nations Economic Commission for Africa. And as you know, the ECA convenes a lot, sometimes ministers of planning, ministers of finance. So the issues sometimes around domestic financing, we can co-convene with UNECA. And finally also, the other working with regional economic communities and the regional health organizations, ECSA-HC, like here, ensuring our synergy with them and WAHO.
Well, thank you very much. And last but not the least, Seth, you are a public health lawyer, quite an interesting title. And you are working with the Center for Health Development. Please tell us about the organization you work for and perhaps the the linkage of what you do to this forum.
Thank you so much. Yes, Seth Nimwesiga is my name. I am from Uganda. I work with the Center for Health, Human Rights and Development. It's a mainstream non-governmental organization in Uganda. Why I say that I am a public health lawyer is that this organization utilizes the law and policy through advocacy, but also litigation. So we need lawyers. Sometimes advocacy is about, baby and writing statements and doing what. Sometimes litigation, you have an order of court that you can compel the next person to implement what you're looking for. Unfortunately, yesterday someone here said everyone is being introduced as doctor. I am working on this. Not a medical doctor, but inshallah, by the grace of God, I'll also be a doctor one day by title. The Center for Health primarily works with governments to integrate policy related to health. Now, our relevance here is in relation to our role as a member of the Self-Care Trailblazer Group. This is an umbrella, a coalition of over 400 members across the world that are looking to support the localization of the WHO self-care agenda. In 2019, the World Health Organization passed guidelines for self-care or health and well-being, and we are looking to see that self-care is streamlined or institutionalized in our different governments. I have just checked in the ECSA member states, only Uganda and Kenya have so far done some progress towards localizing guidelines for self-care from the WHO. And if it was within my power, maybe there would be a session 10 on self-care, because I think from the bulk of discussions is issues of dwindling financing, issues of human resources for health, issues of all these problems that we are suffering with. The doctor-patient ratio in some of our region is still very high compared to the target of WHO 1 to 1,000. Someone presented yesterday and I was just raising my eyebrows. I think I saw in Tanzania it's about 1 to 20,000. In Uganda it's around the same number. But we believe that through self-care, empowering individuals to take care of their own health will lessen the burden, will lessen the overload on the health facilities, will lessen the burden of the cost that we have to implement. We are so focused on curative services, but I think it's, from the discussions on health financing, I think it's unsustainable. And for this, I think I made a personal commitment that in the next health ECSA Ministry meeting, I will volunteer my time that we have a session on self-care so that we lessen some of these problems we have with human resources for health and the cost of health care. So we are here to discuss how we can partner to do that, and I bring you greetings from Sehan Uganda and the Self-Care Trailblazer Group.
Thank you very much, Seth. We will get back to you, Dr. Ahmed, and I would like to get your thoughts on how you think Village Reach would be able to partner with ECSA and indeed other partners in strengthening primary health care, which you emphasized is the core business of Village Reach. Issues around strengthening supply chain, data systems, to name but a few. I know it is it's system-wide. Really, what do you see your role to be in strengthening primary health care?
Thank you very much, Ceremony. And just to say, we are already working with ECSA. Part of the reason why I'm actually here, and it's a pleasure to be back in the ECSA forum. Primary healthcare is a system, and to deliver on that system, there are things that we need to do. One of them is partnering, and there are three big things that I think, as we continue to explore further work with ECSA, will be very useful looking at the strength, mandate, and area of operation of ECSA. The first is on women's health. Today, a lot of the discussions around women's health is only on the reproduction part. And in fact, after a mother has delivered, the second question she's asked is usually whether the child had breastfed. How is the child? Did they sleep well? Very rarely is the mother asked, how are you? Did you eat? Are you okay? Usually we are very focused on the child. So the mother is, the woman is seen as reproduction, quote unquote, and not much else. At Village Reach, working at the community level, and what we see, 60 or thereabouts % of those we engage with at the community level are actually women. And we see challenges beyond the woman as a reproduction entity. And we would like to have that strengthened so that we see the woman in total, and whichever stage of life they are in, they are provided with the best access to health, not health care, to health, so that we step away from disease and problems and we enter into the space of discussing how do we maintain a community's health through supporting the woman to be healthy throughout her life cycle. So this is an area that we'll continue to explore and expand. We already held one very good event at the UN General Assembly last year. ECSA supported very well. We have another one in a few weeks in Addis Ababa during the Africa Union Summit, and we hope that the ECSA members will be able to attend that, because we are looking to see how do we get to an African position on women's health, not women's illnesses. How do we get to a framework on the continent that addresses women's health and not women's illnesses? So this is one big area. Second, and I think this, let me start by saying when you're slapped, you wake up. And I think earlier this year, someone in Washington, D.C. slapped global health very hard, and we woke up. The only challenge is when we woke up, what were we looking for? Were we looking for the door to run out, or were we looking for whoever slapped us to figure out why we are being slapped? My sense is we were looking for the door to run out. We are not asking why we were slapped. And if you look at global health today, including all the projects that we are handling at community level, the model that is being used is very expensive. And that's why when the funding stopped, I come from a particular county in Kenya called Homa Bay, and when I went to see the governor, there were 23 vehicles, 4x4 vehicles parked that were project vehicles. I doubt you as minister today would allocate 23 4x4 vehicles to your health projects, because there are more critical issues that money needs to do. The models that we've been using to deliver healthcare to the community are very expensive. And the example I will give is with the DRC recently, the Ebola outbreak that has just been controlled. The government of DRC asked Village Reach to handle lab sample transport. So we had options, including sending airplanes to the area that was affected. But we couldn't afford that. So what we did is we engaged with local innovation, the motorbike. And the first samples that eventually told us that we had Ebola were actually transported by motorbikes. From the center, it is 500-600 kilometers away, to Kinshasa. You use what is most affordable to you. And this is something that we would like to work with ECSA in looking at these delivery models that we are using. How expensive are they? Can we afford them? Are there alternatives? And when we are innovating, we innovate with the context in mind. We don't innovate for things that cannot be able to be delivered in the communities that we live. And finally, is we have this very important, I think, culture in Africa where we give our leaders all the support that they need. Unfortunately, our leaders are not superhuman and they need support themselves. But we forget to support those who support the leaders. And I think looking at what ECSA has been doing and the focus that we have as Village Reach, we would like to think around how do we support senior officials within ministries of health so that they have the capacity, the knowledge, the capability of supporting the leaders, whether it is ministers or heads of states, in a way that makes sense for the health sector here on the continent of Africa. And to end, I will say it's not a challenge, but it is an ask to the honorable ministers that let's think big. Let's really think big for this continent. Not big in the context of someone else's capacity, but in our own context. Eliminating malaria should be something that we can do within 5 to 6 years. It doesn't have to wait until 20, whatever the target was. We can be able to do it today if we think big and we deliver on very big impact for the communities that we serve. The African saying is, if you want to go alone, if you want to go fast, you go alone, right? And if you want to go far, you go together. I can persuade you that we can be able to go far and fast by being innovative, context-specific, and delivering big impact for the communities that we are serving. Thank you.
Thank you, Dr. Ahmed. Indeed, that deserved a round of applause. We'll move quickly, and I see that our time is racing. Beth, I'm aware that the Commonwealth Pharmaceutical Association has a big focus on human capital development. Kindly tell us about where you see the association supporting ECSA efforts to develop human capital.
Yeah, thank you. Just reflecting back on the last few days, I think some key priorities that keep coming through have been around local manufacturing, around primary healthcare, around supply chains and non-communicable diseases and mental health. And I think for us, we see that the pharmacist workforce is absolutely fundamental to delivering on the priorities of all of these areas. And so strengthening the pharmacist workforce and pharmaceutical systems can really be of benefit to countries across the region. So I guess one of the core ways we think that we can add value to the region is through strengthening workforce development across the region. Some of the discussions that we had on the pre-conference on AMR was around what a collegiate model, like a college of pharmacists within the ECSA region, could look like. And I'm thrilled to say I am joined by presidents and vice presidents of national pharmacy associations from 6 ECSA region countries who are here today as well. There's unanimous support to see about how we can harness this cross-border collaboration to strengthen the systems, and thinking through a capable and confident workforce that's able to support local manufacturing, that's able to deliver primary healthcare through community services, which when you look at community pharmacists are the 3rd largest profession across the globe in terms of healthcare. They're one of the most accessible professionals out in the community, but we often see that they're underutilised. And so it's at time that we start to utilise these systems. We're seeing examples across other parts of the Africa region where pharmacists are delivering primary healthcare services, doing those health checks. They're embedded within the communities already, so let's capitalise on that already. And then when we think about local manufacturing, and also this is kind of building on a model that we've been working with countries for the last few years around antimicrobial stewardship. So the CPA has led an African leadership fellowship in partnership with countries and partners on the ground to see how we can support the development and advancement of leaders in country who have led antimicrobial stewardship projects that have resulted in demonstrable impact towards achieving the targets set by the national action plans. So there have been over 70 fellows who've graduated through this system and are now, you can see them rising up the ranks. We've got now pharmacists in Ministry of Health level positions, but the kind of projects that they're doing are very locally based. They're doing things like, improving adherence to guidelines. They're ensuring that the appropriate use of antimicrobials is happening so that the patient gets the right medicine at the right time, which also, apart from impacting antimicrobial resistance, it's reducing waste and reducing costs across the system as well. And this is what we can do when we see that we provide these individuals with leadership training and support. So the healthcare workforce, I think I was thrilled to hear earlier and the statements from the ministers that that's a real area of focus. And we see that the collegiate model for pharmacists could work very well, and the CPA is very happy to be supporting that model to develop in the region to strengthen the workforce and deliver on priorities.
Well, thank you very much. That's really exciting to hear. Dr. Ambrose, I'll skip you a bit and move on to Seth, because I deliberately want you to come and sort of speak to some more cross-cutting issues. Very quickly, Seth, tell us a bit in a couple of minutes, to what extent have partnerships between government and CSOs set the ground for self-care integration in the broader health service delivery? I know you already started speaking about self-care, and just to speak briefly to the role of civil society.
Okay, so yeah, my presumption is that everyone knows about self-care. Just briefly is that WHO has helped us to define it as the ability of individuals or communities or families to manage their own health, with or without the need to have a health worker, which is really a great step in terms of reducing the overload of health facilities. Like I already said, is that we are in the self-care trailblazer group. What we are trying to do is help the countries that are integrating self-care to be able to align their policies and frameworks. In Uganda, for example, in 2024, through the Ministry of Health and of course with the partnership with civil society and other partners, were able to launch the national guidelines on self-care for health and well-being. This is localizing the guidelines from WHO. WHO in 2019 provided guidelines for self-care for sexual and reproductive health, just for sexual and reproductive health, and then revised them in 2022 to include more upcoming recommendations like self-care for mental health, self-care for older persons, self-care for non-communicable diseases, etc., etc. And that's what we are trying to do in Uganda. For example, we have integrated self-care for mental health as a key component of primary health care services. We are also working with ministry to develop a dashboard. Already have a running dashboard to develop what everyone is doing, what all the partners are doing in different regions that we implement this project in. We have piloted the guidelines, and like I already said, is that if we are given the space at the next ECSA Health Ministers Conference, we shall come and talk about things like the cost of commodities, etc. Countries like Kenya and Uganda will come here and make statements of the progress and the benefits we have got from self-care and easing the burden on the healthcare system. Gladly, countries like Eswatini have found out that are doing very well in terms of healthcare professionals for the population. And so this is going to be a game changer. I have also learned that the WHO has included self-care as part of its next agenda, as an agenda item in its next executive board meeting, I think happening very soon. And from that, if that happens, is that the WHO is likely to adopt its resolution made at the World Health Assembly that happened last year. If that is adopted, it will mean that all of us countries will have no choice, or rather will be persuaded to all adopt self-care and align it within our national frameworks as a means to foster universal health coverage. Thank you.
Thank you so much. Thank you, Seth. Dr. Ambrose, back to you. You are a health advisor, and kindly give us advice around the need to strengthen collaboration rather than fragmentation, duplication, competition, particularly against the backdrop of declining ODA among the various partners.
Thank you very much. I think the narrative starts from partnerships for resilient health systems in Africa. And it has been defined severally, but really, if we were to build a resilient system, that is a system that is able to forecast, prevent sometimes, promptly detect, and timely respond to, recover to any shock event, any acute, protracted. But at the same time, it must also be able to, during the shock event, you have to maintain the continuity of essential services, a package of essential services that have been defined. Now, if that's the definition, then really several partners are likely to be involved in that space. WHO, Africa CDC, ECSA, WAHO, and more. But the critical point is, if we're involved in that space, do we complement what we do? Do we synergize what we do? And for us as WHO, we learned this when heads of state established the Africa CDC, for example. And the Africa CDC statute said that there must be collaboration with WHO. So the first thing that we did, and remember, I think this was my first assignment in WHO in 2015, was write a framework of collaboration between WHO and the establishment of Africa CDC then, including the regional coordinating centers. Initially, the scope of work of Africa CDC was mainly emergencies, but now it has broadened to everything. So how do we synergize and complement each other? We've now moved from that framework to a revised framework that looks at Africa CDC's big mandate now, including primary healthcare, non-communicable diseases, and communicable diseases. And so the framework of collaboration stipulates areas where we are going to complement and synergize each other. We've done the same for ECSA now, and this framework was signed by our regional director and the DG ECSA just a month ago. And there are a couple of areas where we have agreed that we will collaborate. And this is really to avoid duplication. And this, for me, this is really the future to go. So as long as we have demarcated functional areas, sometimes geographical areas, and what we do complements each other, we can all be in this market space. But really, we need to clarify on which areas we are going to collaborate. For WAHO is exactly the same, and also for United Nations Economic Commission. So even at country level, I think we see some partners. So we are doing this at the continental level. And in Addis, for example, we have now the Health Partners Group, where we meet ordinarily and partners share what we are doing. At country level, normally this exists. Countries have partners groups that meet eventually at the continental level. We didn't have this. So in Addis now we frequently meet as Health Partners Group at the continental level to see who is doing what where and who is funding who. So that what we do complements each other. But we want also this to be reflected a lot and at country level, because the Health Partners Group sometimes at country level can be a bit fragmented. I know for my country they've been meeting quite often. I was at the Uganda Ministry of Health a couple of years ago. But also countries like, probably here, you have also a Health Partners Group. The other is, sometimes when we look at the health sector, we don't look at it from the One Health approach. But if we are really going to do a multi-sectoral approach, there are partners that we don't traditionally work with. They're working in animal health. They're working in environmental health. We need to be bringing them on board, and that they are all contributing to this partnership. So by and large, I think we can all work in that space. And like my regional director has really come up with this slogan, we are building the same house. We shouldn't be fighting for bricks.
Thank you very much. I think that's a very good one, which requires a round of applause. We are building the same house, and we don't need to fight over the bricks. Well, I wish we had more time to share, to have you share what you are doing and the opportunities you see for partnerships. But take homes from Village Reach. I get the underscore on women health, really important. workforce development, for CPA. We thank you for that support. WHO, thank you for continuing to be the factor that brings us together and coordinates us. And also, again, some emphasis on self-care from Sehut. Ladies and gentlemen, we will end our panel discussion here. Thank you so much.
Let us all clap hands for our moderator and speakers. Thank you. Before we go for break, let us have the second panel discussion to be moderated by Dr. Jones Masia. Dr. Jones Masia, please come forward to start the proceedings.
Thank you very much, Chairperson, honorable ministers. But I think before I start, Chair, give me just a minute. We've been seated for long. So we are in non-communicable diseases. Maybe I invite the members to stand. So, Chairperson, I just want a quick energizer. So normally what I want is we'll be counting, starting from our right hand. 1, 2, 3, 4, 5. Then the other one, right leg and left. Then we go down, 1, 2, 3, 4, all the way up to 1. So I believe we have the space. All right. Let's begin our exercise with the right hand, counting 1 to 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2. 1, 2. 1, 2. 1, 2. 1, 1, 1, 1. Excellent. Thank you very much. Thank you. Chairperson, let me thank my colleague, Dr. Srumes, and the panel for the job well done. We are continuing on the same partnership. You agree with me, Chairperson, and honorable ministers and leaders of delegation, that globally, recent shocks, whether pandemics or climate-related emergencies, the funding landscape, you agree with me that it has left our health systems fragile. So surely no single actor can build this health system alone. Thank you very much, Village Leach, for saying if we want to go far, surely we have to go as a team. But if you want to be quick, do it alone. I do believe by the time we leave this conference room, we'll go as a team so that we go very far. Chairperson, allow me to introduce 3 distinguished speakers to continue on the partnership. Most of them, we know them. They have been on the platform couple of times. Let me start with Ladeo. Ladeo will be presented by Karen Lindy. She's the CEO for this institution, somebody with experience in global development, particularly on maternal and newborn health, technology and innovation. Welcome to the podium. Secondly, let me call Professor Josh. Prof. Josh, he's an innovator, he's a researcher, he's an educator. If you want to be mentored, this is the man we have to look up to. Welcome, Prof. Finally, but not least, let me welcome our own colleague. This is Linton Nchum, who is a senior advisor at Auda NEPAD, a gentleman who is focusing on strengthening health systems and making sure that we put policies in place in Africa to unlock that potential for the youth. As you can see, he's a youth himself. Welcome. Thank you very much and welcome. So like my previous speaker, we have been given some 30 minutes. I'll ask you some questions. I know you are experts and the members are here to hear how we can partner together to make sure that the health systems become very strong. So allow me, Chairperson, to start with Radio Global Health. This is Caroline. So how can Radio Global Health support frontline healthcare workers, training and quality improvement, and also emergency care systems to strengthen primary health care and resiliency in the member states? I know my colleague, Dr. Shiva, will be happy to hear about primary health care. Over to you, Karen.
Thank you. There we go. Thank you very much. Maybe first, for those who don't know Lardal, which is a very complicated name, how many here has ever done a training, like a CPR training on a mannequin or helping babies breathe, know about neonatal? Could you raise your hand so I just know neonatally live or Mama Natalie training? Okay. So Lardal is the company that's been working with partners to develop these tools. And Lardal's been working with developing training tools, mannequins, simulators, but also digital tools and medical devices for training healthcare workers since 1960. But in 2010, we started working on this. Because our mission is helping save lives, we said, where would we be able to help save the most lives? That's in settings with the highest mortality. So in 2010, we established a not-for-profit company called Lardal Global Health that was focusing only on maternal newborn health and the countries with the highest mortality. What we did then was developing tools like actually courses like Helping Babies Breathe, which later was a collaboration with the WHO to create the new Essential Newborn Care course, and we've developed mannequins and for implementing them. What we see is that it's not about the tools, it's about how you implement. We've been in this business now for 1960, 60 years, 65 years. And what we see is that if we're gonna have healthcare workers change their behavior, you have to shift the training to happen at the facility, and you have to give them the supportive tools for quality improvement. This is one of the things that we did now recently in a program called Safer Births Bundle of Care in Tanzania, together with partners and the government. We shifted the training on newborn resuscitation, on postpartum hemorrhage, on safe delivery to happen in weekly drills. They train 2 to 3 times per week. And what we saw then was that they were able to reduce mortality by 75%, maternal mortality by 75%. These results were published in the New England Journal last February, and they also showed a reduction in newborn mortality by 40%. And now comes my point. After these results started coming out on the newborn and maternal side, WHO approached us and said, we believe that we could do the same things in strengthening acute care systems. So, for the past 3 years, we've been working with WHO on looking into how can we support them in further developing the basic emergency care course in order to do the same thing there, have mannequins that you can place in the facility, shift the training to happen at the facility. Then you don't have to take people out of the facility. I was in Nepal actually a few weeks ago, and they told me, I was in one of the regions, and he said they had 60% absenteeism because their healthcare workers were going for trainings and capacity buildings outside the facility. So by shifting the training to happen at the facility, giving them the tools at the facility to train, but also building the capacity of healthcare workers to run simulation trainings, we developed a course called SimBegin. We believe that we can see similar results on the acute care systems. And so I think, what can we do? One of the things I think is important is we always work in partnership. So we have some insights, some research. We need more research, but we do have concrete tools and partnerships and proven evidence that you need to shift training to happen at the facility, and it needs to be incorporated into the system and with quality improvement. That's not just giving you better quality of training, it's also more cost effective. It's a lot cheaper to keep the training rolling at the facility than taking people out. And I'm very proud, using my last 30 seconds, to say that we've been having good conversations with ECSA lately on how we can work together using their platform and their mandate of scaling innovations to bring this to the ECSA member countries. Thank you.
Thank you very much, Karen, for that. Let me go to Prof. Josh. So, Prof, I know you are in academia. Please, how can the University of Memphis support research, workforce development, digital innovation, to make sure that we strengthen evidence-based health systems across the region, ECSA region? Over to you.
Thank you so much. First of all, I just want to acknowledge the Chair and the Honorable Chair and ECSA for giving me an opportunity to be on this platform. This is my first visit to the Eswatini, so I'm very honored and humbled to be here. Let me just begin by saying one thing. I lost my father when I was in a medical school, second year. And I want to give an example of that, what he said. He said, my son, grow like an old tree. An old tree does not grow vertical, it grows horizontal, which means if you get success, be humble so that you can give shelter to many. So before we talk about our credentials, I just wanted to stand where the values are important. It's very important to have those values. So the University of Memphis School of Public Health, I'm not a traditional dean. I don't think like a traditional dean. I think we in academia are sometimes only focusing on providing education and research, community partnerships, and if the research funds and projects end, and then mistrust happens. And this was an opportunity as a dean for myself to have a very clear vision about the School of Public Health at the University of Memphis. A lot of people may not know Memphis is in the southern part of the United States, in the state of Tennessee, and has one of the lowest social economic health indicators in the United States. So it's surprising, and I always say that there's a good and the bad side of the health. And why University of Memphis School of Public Health? Our vision is not to become a big school of public health. Our vision is to become an impactful school of public health. And impact is a very important element. So in that space, the first priority for the School of Public Health is to be community engaged School of Public Health, which means you need to work with the community partners. and that's where our role and commitment is to ECSA health community. The second thing is, I don't use the word local or global. I know my dear DG knows it pretty well. I use the word glocal. There's nothing for me global. It's glocal. Everything what is happening here is going to impact something that is happening somewhere else. Yes, COVID may have taught us that, but we are a global school of public health. The third thing, we are anchored in the community, which means we need to make sure that whatever we do, how are we translating our academic setting beyond the walls of academia? A lot of times the word is used research, and I am very hesitant to use the word research alone. I say we need to do research-based solutions, not just research. Research needs to be published, it's great, but it needs to be translated into practice. Fourth, which is very important, if things are not working, we need to think and change ourselves. We need to rethink and reimagine public health. We don't need to reinvent public health, we need to reimagine. So entrepreneurship and innovation is a very important element. And lastly, who are going to bring change? It's the students, the youth, and the young. So we need to create more public health ambassadors. So only three things I will say that I'm very delighted to share. That we are the only school of public health in the US and in the globe that has brought public health education to the high schools. Which means student in grade 11th and 12th is getting exposed to the field of public health. So if you want to address issues of health system strengthening, and that's where our first collaboration is happening with ECSA. I get very passionate, so allow me to say it just because it's a lot of passion there behind this. The second component, which is very important, is that we want to invest in the youth much earlier than they go to the university settings. So we are the only school that is also establishing public health clubs in the high schools. We see chess club, we talk about robotics club, we talk about technology club, but why not public health club? Yeah. That's a very important element. So I think that's where our second collaboration will come with ECSA to build and bring these public health clubs to the entire Africa. The third area, I know we talk about global health diplomacy, we talk about health diplomacy, and I use the word public health diplomacy. A public health diplomacy, which basically means that we need to engage local, global stakeholders, everyone. We can't just impact globally unless we focus also on the local side. So that's where the three areas are there. I leave for the rest, but thank you for giving me this chance to just share my passion with you all.
Right, thank you very much, Prof, for that, for those remarks. I know I'll come back to you with one more question. Let's cross over now to Auda Nepad, our colleague Linton. We just want to find out how can Auda Nepad mobilize investment, branded finance, and strategic partnerships for supporting resilient health systems we're talking about, to make sure that they're aligned with the ECSA Health Community Strategic Plan 2024-2034. Thank you.
Yeah, well, thank you very much, Program Director. I think certainly we have a role to mobilize resources and ensure that we bring everybody around the table. And we know that we have a $66 billion financing gap in the health space per annum. And we, as member states, are only contributing less than 5% in some instances, and in some instances a little bit more. So we try and bridge that gap. So beyond us having to do the work, indeed, we encourage member states to do that. Essentially, our sort of funding ecosystem, or the way in which we conduct funding is through a number of areas. Firstly, we have funding partners, And of course, these are, they provide financial resources based on our identified priorities, and of course that of the continent. And in most instances, of course, we know that these are aligned to their individual interests. And here we are talking philanthropy, we are talking banks in some instances, and even private sector in some instances. And then, of course, we have technical partners, and in this regard, they provide specialized technical expertise and solutions, supporting us in terms of developing systems, designing systems, and of course implementation. And sometimes these don't necessarily bring money as such, but they bring their expertise to assist us in terms of tools and various platforms, technology platforms, for example, that we can utilize. And then, of course, we have development partners, which I think we're all familiar with, and these are, of course, largely within the format of multilaterals, and in some instances even bilaterals from various member states in the form of ODA, as we all know it. And then, of course, you have what we have as implementing partners, and of course these cuts across, they give us, in some instances they would give us advisors and support that would sit in our ecosystem to ensure a level of implementation. But sometimes we know the realities of this one. They say that you must procure from our supply chains, if you like, or if you look at the entire value chain, sometimes they would say procure from us. And of course, sometimes this is our own partners that we have, whether it be internal RECs, member states, think tanks, CSOs, some that we would initiate on our own. And then, of course, we like to look at citizens as partners as well, because they're not just beneficiaries, but they're also partners. They tell our story, and they're the reason why we do the work that we do. So what we've done is we've established a development fund. And within the context of this development fund, institutions like ECSA and member states are going to be able to, get support, and health is one of the key pillars of this development fund, where you'll be able to get a level of support from the work that we do in this regard. So very quickly, I indicated yesterday that we mobilize around just north of 191 million per annum. And in those 5 areas that I highlighted, that's how we spread our funding effectively. We get rather funding in that regard, and then we are able to distribute it in some instances to member states, to regional economic communities, even to civil society. We open calls on a regular basis. And so, it's always important to just keep abreast of what we are doing, getting onto a website, keeping in touch with us, and you'll see some of the initiatives that one can benefit from. So this 191 million that I spoke about yesterday, the truth of the matter is that 98% of that money does not come from member states. It comes from development partners. 98%. And the truth of the matter is that he who pays the piper. Aha. So that's why in some instances we struggle to go into some countries, because the donors are saying, no, don't go there, go there. And we put up a case and say, no, but we are a continental institution. We have to go everywhere. And so sometimes we are faced with those challenges, and we can only address those challenges if we invest our own money for our own ownership. So if we think that we own these programs, we don't. They may be domiciled in our countries, but they're owned across the ocean in some instances. So the only way we can avert that is that if we put our own money. We've noticed an interesting trend in the past 3 years. Apart from donor fatigue, what we are seeing is that some donors are moving away from going bilaterally to countries. They prefer to come to institutions like ourselves, who have a bird's eye view, have a level of coordination, are able to produce rapid results, we have systems and capacity to implement, to monitor, and to evaluate. And of course, one of our selling points is that we have a consistent execution rate in terms of our institution of 97 to 98% annually, and we've received clean audits throughout. We have the highest level of funding throughout the entire organ of the AU, and we are able to demonstrate results at a very quick level. And so partners, in the past few years, we've seen a 10 to 12% surge or increase in sub-delegation. So where some partners are saying, We used to go to country X and country Y. We have problems. Bureaucracy is a problem in member states. Let us come to you. You seem to have a better way of operating this thing. You have convening power, etc., etc. So those are just some of the challenges, that, some of the ways in which we do this. Of course, we still rely heavily on donor funding, and even in terms of assessed contributions, it's still very low for member states. So we have to change this narrative, and the only way to change it is if we become owners in our own space. And again, the opportunities are multiple.
Thank you very much, Linton. I think I'll give you 2 more minutes at the end. Thank you very much for that. So in the interest of time, I think let me go back to Caroline. I just want your concluding remarks. However, as you're concluding, if we can talk about maybe developing a regional training platforms. You know, ECSA Health Community, we have the College of Health Sciences. What can we do together to make sure that we can have those training platforms? Thank you.
Yeah, no, thank you very much, and it's very interesting to listen to my colleagues here and also on the funding dynamics, and that's why we need partnerships with, and why also I think just a little bit of a perspective from my side. I feel that the regional organizations like AUDA NEPAD, African Union, Africa CDC, ECSA is really gaining importance on the global stage, to be honest. And Lardal has, ever since we started working in these countries, actually partnered with ECSA. They were our first partner back in 2011, 10, 12. And I really think that the convening power is really important, but also, back to your questions, building on ECSA's platform of colleges and partner universities. And more concretely, what we think that we could do together, and some of the conversations we've been having, is how can we, as Lardal and our partners, help develop these centers of colleges into also centers of excellence for simulation and competency-based education. We've heard from multiple places that there's an increase in institutional deliveries, for instance. So the coverage is getting better, but the quality of services delivered are not up to standard. So we need to invest even more in building our health workforce. And I think that we know that simulation training is the way to do that, and so a very concrete thing is to work with ECSA on how can we build that competence for their colleges, so that we can help support governments on implementing innovations like Safer Birth Bundle of Care or the Basic Emergency Care course or other training courses. Thank you.
Excellent. Thank you very much, Rado and Karen, for that. Prof, I know you are a researcher and you are at an institution where research is being done, and the ECSA Health Community, one of the strategic objectives is on research. Just want to find out what joint research platforms that we can work together, University of Memphis and the ECSA Health Community and also the region at large. Thank you.
Thank you so much. I think I'm glad that you highlight that importance of research. I think, to be honest, research must start much earlier. Much earlier, maybe at the school level. We must invest in research and development. That is the paramount importance, because our whole hope is that with ECSA we can actually create research and innovation hubs that allow them to create solutions that are accessible, affordable, available, and also not to just invest the money in things that are not working, but also to know what is not working. So that it's very important that if research is happening. So the second thing is that digitization. We can't ignore the fact of digital innovations. As I was hearing some of the Honorable Minister's comments, we need a trained workforce that is able to understand the right and the wrong use of technology. So I think responsible and ethical use of artificial intelligence in public health is a very, very important element. And the last thing I would say is we live in a world of uncertainty, complexity, and unpredictability. If we are not training our workforce to know how to respond to that, then there is going to be a fundamental gap in that area. So I'm hoping that with ECSA and its network, we are able to build these hubs that might happen at the high school level so that we are not waiting them to come into the college, but actually give them an opportunity not to find a job, but also to become more like creators of those jobs and social impact organizations. Thank you.
Thank you very much. Yes, let me finally go to Linton. So, Linton, I know Auda NEPAD, you have done a lot, but we know there are more investments that are in the pipeline. We just want to find out which investments can be prioritized in the region. Thank you.
Thank you very much. 2 days ago, yesterday, Sima and myself, during the health financing meeting, spoke at length around the work we are doing around PIFA. And through the PIFA platform, we've created a project preparation facility which enables member states and private sector and institutions to provide projects. We do the work of making sure that the projects that are in that platform are bankable, because investors are looking for bankable projects. You can't go to a banker and you give him a project that's not going to yield any returns. They want bankable projects. So we've created this project facility, and unfortunately we've closed the call now, but we'll open it again in the next 3 months or so, and we are now running through those projects. Those projects, we're going to invite partners and investors in. We've developed a development fund where we are going to see some of the strategic ones, and of course, they must have a regional approach to them. And so that's one avenue. A second avenue is a very important avenue which we sometimes take for granted. That's the pharmaceutical sector, the pharmaceuticals industry. Africa is seen as the next frontier or the last frontier for the pharmaceutical industry. So the globe would want to keep us as a market, right? And would do anything to support us in keeping the market open. The operative word there is market. So they would support us in terms of regulation, they would support us in terms of harmonization standards, etc. But it's very difficult to find them directly supporting when it comes to local manufacturing. Because they know once we get ready and once we are able to manufacture, produce on our own, we have a massive market. So that's one of the reasons, by the way, why the PMPA is stuck. Let's be honest. The Pharmaceutical Manufacturing Plan for Africa is stuck, but our other programs like AMRH are moving drastically. So that's a reality, and so we have to exploit, this specific space. Lastly, I will just say 3 things. One, we can't do anything without partnerships. You saw we rely 98% on donors. So donors and partners are important. But we have to make sure that the manner in which we do it is, firstly, is based on solidarity, very important. It's based on accountability, based on trust, based on equality, based on sustainability, and most importantly is coordinated. If we don't do that, we're in trouble. And again, he who pays the piper plays the tune. That's the reality. We can't run from it. And I wish we could, just last 2 examples with ECSA, we've started doing some significant work. I mean, we only signed last year, Doc, right? DG, I think we only signed last year with you, towards the end of last year. And already we're starting to see traction in a number of areas of the work that we are going to be doing. Stuff with the colleges around nursing and midwifery. We're doing some work on health financing. We're doing some work on SRH and demographic dividend. And we're going to expand that because we think that ECSA has the right platform for us to advance some of the work that we're doing. And our role is to empower regional institutions and member states. And so we're doing that with ECSA, with a number of other recs, and of course member states. Homegrown solutions. I wish I had more time to talk about what we're doing with MUHAS, based in Tanzania, where we are blending the private sector, we are blending government, the pharma sector, as well as civil society, and we're working together within the context of the pharmaceutical industry. Thank you.
Thank you very much, Linton. Let me once again thank you, our panelists. I wish I had more time just to summarize what you guys have, articulated. However, one thing that I've noted is we are saying it is not about the tools, but how we implement them. We have a lot of policies, but how are we implementing them? And you have talked about public health diplomacy. Prof, this is an issue, this is high on the agenda at ECSA Health Community, health diplomacy. So we'll reach out to make sure that the member states benefit on what you are doing. And Linton, you've talked about pharmaceutical industry. I think this we have talked about it, that as a region, we need now to invest into this. So once again, Chairperson, Honorable Ministers, let's give another hand of applause for our panelists. Thank you very much.
Thank you, moderator. That marks the end of session 9. Thank you to all the panelists. We will take a 15 minutes break. Then when we come back, we will have one presentation in session 8 by the ECSA Secretariat. There will be no statement from Kenya as indicated in the program, since they are not represented in this meeting. Then we will have member state statements. After that, we will have the draft resolutions for adoption before our last item, which is the closing ceremony to be directed by the PS Eswatini. Details of the excursion will be displayed on the screen during break. Please do take note of the available options. Thank you. We may go for our 15 minutes break. Thank you for your attention. Please, can we have the ECSA Secretariat coming forward? Yes, Evelyn, to make a presentation on the ECSA regional progress and recommendations on access to effective AMR countermeasures. Thank you, Evelyn.
Honorable Minister in chair of the session, allow me to stand on the protocols that have already been established. And I just want also to really say that we are grateful for this opportunity to be able to present the regional progress and recommendations on access to effective AMR countermeasures. And this is coming in at a very timely moment because mid this year in June, the world will have its eyes on Africa. Why? Because Nigeria will be hosting the 5th Global Ministerial High-Level Meeting on MR to track progress that has been made globally following the United Nations General High-Level Meeting on MR in 2024, which was followed by the 4th Global Ministerial High-Level Meeting that was held in Jeddah. And in this photo, you can see that baton being handed over to Africa. So we have a big role to play in terms of preparing for this session. Why are we concerned about antimicrobial resistance? And I always like to make this presentation by making reference to Alexander Fleming. If Alexander Fleming did not discover penicillin, we probably would not be talking about antimicrobial resistance. But in his early years, even before he received the Nobel Prize, he talked about that time that will come when the ignorant man will use antibiotics irrationally and subject microbes to unnecessarily low doses and propagating antimicrobial resistance. And we are at a point in time where now AMR is at a tipping point, and as you can see from that image there, the data that's projected, the font in red refers to statistics from sub-Saharan Africa. About 25% of the burden of AMR is borne by the continent. And unfortunately, it also disproportionately affects our countries where our systems are weak and fragile. We have limited diagnostic capacity. Even as we go on this conversation around local manufacturing, I think it's not just about medicines, but diagnostics and vaccines as well. And I think apart from that, also the aspect on restricted access to effective antimicrobial agents. Unfortunately, AMR is not as simple as many other diseases. The ecosystem is very complicated, and normally we find it very hard to fit the entire ecosystem in one image because it looks at impacts on the environment, in animal health, and on human health. And you can see the interconnectedness of the ecosystem. And unfortunately, the brunt is borne by older adults over 70 years, and the very young, the newborns. They are the most vulnerable populations. And how are our systems positioned to protect this particular population? And this actually is contributed to by undertreatment, largely maybe because of poor diagnosis and limited access, and also leading to poor outcomes. And on animal health, there's severe impact because what we've realized is that similar molecules that are used in human health are also used for either treatment or growth promotion in animal health. And we estimate the losses to about 746 million people being affected. So we can see the impact is great on mortality, on healthcare costs, food security, and of course, ultimately, the global economy. But what we are saying is for us in this part of the world, just improved prevention measures have a big impact in terms of slowing down the growth of antimicrobial resistance. We are talking about improving our water, sanitation and hygiene, infection prevention and control practices, looking at embedding this in community engagements, primary health care, universal health coverage, and also improving access to quality and effective antibiotics. This can actually avert over 50 million deaths by 2050. These are reports that have been provided by the World Bank and also the International Health Metrics team as well that have done a simulation on this. And we are saying investing in prevention measures for every $28 that is invested in AMR prevention measures, you actually are able to have good returns. For every dollar that's invested, you get a return of $28. We are talking about commitments and progress because we are part of the Global Action Plan on AMR that was sent out in 2015, and currently there is a draft that is under development, acknowledging the Agenda 2063 of the Africa we want, and you can see also an African common position on antimicrobial resistance that was made by the heads of state, and of course looking at many other aspects that guide the interventions that each of our countries subscribe to. Some of the targets that were set by the political declaration in 2024 asked our countries to commit to reduce AMR-related deaths by 2030 by up to 10%. Do we currently know where we are in terms of that particular target? The aspect of financing I will not belabor because we've talked so much about financing and handling this from a One Health approach because it cuts across sectors. And this was also translated to the ministerial summit that I talked about, and we similarly embraced the commitments. So in terms of the priorities that have been determined through the Africa Union Landmark Report on AMR, there are areas where as a continent we are not doing very well. And on IPC, for example, on using data to make decisions, we are still lagging, and also in terms of multi-sectoral collaboration. In terms of progress based on previous resolutions that the HMC has endorsed, we committed to strengthening implementation of national action plans on AMR. And you can see the image that's on this particular presentation speaks to creating awareness, and you can be able to locate where your country is actually. Some of our countries are still underdeveloped in terms of developing nationwide AMR awareness campaigns. Others are developed, and others have attained a sustained capacity. And those are some of the commitments that we said we would be able to handle. We also had another resolution that was supposed to support responding to communicable diseases in the ECSA region. Further commitments were made by countries to try and increase domestic financing for AMR and IPC interventions. 10% reduction, I already talked about that, and integration of minimum standards on infection prevention and control into our quality of care and accreditation standards. And at a regional level, we committed to advocate for greater budget allocations towards preventive healthcare initiatives, and also to support regional education and training on both antimicrobial resistance and IPC. So what has ECSA done over the last couple of years as we took on these resolutions year after year? One, we've supported the strengthening of multi-sectoral governance structures within countries, encouraging a whole of society, whole of government approach when it comes to implementing the national action plans, which in essence is a plan that is made up of many other plans from the sectors. We've supported also resistance and surveillance, infection control, stewardship, education, and also not just supporting the generation of data, but supporting countries to analyze, integrate, interpret, translate their data, and use it for policy and guidelines. And these are some of the pieces of work that have been done, not just by ECSA Health Community alone, but in collaboration with many of our regional partners, Africa CDC, WHO, REACT, ICAS, many of them are here, SLM, as we work towards harmonizing our approaches. In terms of progress, I want to really thank the health ministers and the leadership from countries. As you can see, this map is all blue. All the countries in the WHO Afro region currently have a national action plan. This was not the case 5 or 7 years ago, but right now, because of your leadership and support, all the countries at least have a national action plan. But unfortunately, only less than 10% actually have funding to support the implementation of interventions. We are struggling in terms of strengthening multi-sectoral collaboration, and you can see the second graph in between there, just showing the difference between the global region and WHO Afro. Of course, there is marked improvement from 2017 to where we are now, where we are seeing countries beginning to develop their capacities to at least coordinate implementation of action plans from a One Health approach. The next map shows implementation of infection prevention and control measures. We are hoping that by the time we are coming back next year, we will see more greens than the yellows and the orange, meaning that we still have gaps in implementing IPC. In terms of carrying out surveillance to understand the burden and the spread of antimicrobial resistance, we want to appreciate the partners that have walked this journey with the countries. And now we can stand, and every country that at least has a map that's up here can boast of surveillance sites that are not just present, but generating data that is guiding action and policy within the different countries. So you can see that as well. And we can see because of that continuous capacity building for laboratories and countries, over the years from 2016, we have seen our countries not just enroll themselves into the global antimicrobial resistance surveillance system, but they've also been able to submit data to the global repository, meaning there's an increased awareness of the value of actually sharing data as a common public health good because of the importance in shaping guidelines and policies as well. But what we are seeing is that it's only about half of our countries that are currently at this particular capacity. And this has been due to persistent inequity to access to diagnostics. And you can see even in terms of surveillance, data submission has grown over the years, and we want to acknowledge the amount of work that has been put in. And now we are able to know that for the sub-Saharan region, 1 in 5 of all infections that have been reported are actually drug resistant. So that means we are not doing very well in terms of preventing treatable infections, and that means also the cost of treatment will increase, and that will have a ripple effect on many things. And just to flag out these 2 antibiotics that have been a favorite of clinicians, ciprofloxacin has been widely abused. Ceftriaxone, on the other hand, has also been widely abused, and we are seeing resistance rates to up to 70% to both of these antibiotics. The countries have also done well in terms of submitting data on antimicrobial consumption. That means you're able to determine the volumes of antimicrobial agents that we are using. Not every country has been able to do that, but capacity continues to be built. And we can see most of the data submitted is data on first-line or second-line treatment options, and very rarely on the reserve category of antibiotics. And this does not necessarily mean we don't need that third line of treatment, but it also poses a question on whether or not we are unable to access this particular reserve category antibiotics because of the cost implication. So as we think about local manufacturing and the product list that we would want to prioritize as a region, I think this data will be useful. The animal health has also not been left behind. We are seeing surveillance growing, and the animal health colleagues being able to submit data. The color, or the orange countries, means they are enrolled into the World Organization of Animal Health global database on antimicrobial use. And a lot of the antibiotics that are being used are tetracyclines, sulfonamides, and penicillins, similar to what we use. And the red bar you see points towards tetracyclines. And if you're in clinical practice, I don't know how much of tetracyclines we are still using currently, but in animal health, this is like what goes every day. So we talked about foreign cuts, and I will not overemphasize in terms of funding, but what affects every other program, because AMR is a system issue, will affect the ultimate appropriate use of these antimicrobial agents, whether it's a health workforce being laid off, whether it's antimalarial agents being unavailable, or the tests to confirm diagnosis being unavailable. We will go back to treating fever with any other antibiotic that is available, and that will ultimately exacerbate AMR. So this is what the cuts have done. Of course, there will be a disruption in our surveillance systems. Mid last year, the Fleming Fund, which is one of the biggest, has been one of the biggest funders for AMR programs globally, pulled out. And we anticipate a disruption of the surveillance systems and stockouts of critical diagnostic agents that they have supported us with. And of course, that's going to ultimately affect the AMR response because of the withdrawal of the funding. But as we sat through our AMR pre-conference, we started off on a very bleak note, but by the time we were done, we were upbeat because we felt we have some solutions at hand that might actually be able to bridge that gap. Number one is to prioritize the integration of priority AMR interventions into national health and other sector plans and budgets. If we are able to align our interventions to health system strengthening, our WASH plans, our IPC plans, if this work, then AMR will also be reduced significantly. The place of strengthening One Health governance and regional financing and collaboration for AMR, the need to work together as partners in the region is now stronger than before. I think the importance of coordinating approaches cannot be overemphasized. And we would also want to raise political visibility. And the proposal to establish a regional parliamentarian platform or network on AMR that would leverage the existing forum of parliaments of the International Conference of the Great Lake region will be important if we are to rally allocation of finances or funding, and also ensure there's political oversight, not just at a regional level, but also at a national level to enhance advocacy and accountability is critical. As we work towards the high-level meeting in Abuja, we are looking towards developing a common ECSA-HC regional position on AMR. What are we bringing to the table when we go for the ministerial meeting? And I think this is going to be important to guide our coordinated implementation and also foster accountability to one another. And like was alluded to earlier, the importance of building a capable workforce cannot be overemphasized, and the importance of having regional centers of excellence that can support cross-country learning, cross-discipline learning across the borders is important. And the proposal for the consideration of an ECSA College of Pharmacists that will not just speak to these AMR issues, but also address gaps in local manufacturing and other medicine safety-related aspects becomes very important. So in local manufacturing, as much as we want to manufacture locally, market guarantees become an important aspect to support the local manufacturers. And again, investing in fit-for-purpose workforce development becomes important. Who will work in the manufacturing companies that we are setting up? Are we going to import expertise? So we need to build a fit-for-purpose workforce for this particular reason. And finally, technology transfer is important. As we have equipment, as we have technologies that we adapt, I think it is important to have in-house capacity for sustainability and smooth running of processes. So this is my final slide, just as, again, I alluded to the fifth high-level ministerial conference. We are looking forward to seeing all our health ministers present in this, just to reaffirm their commitment to sustaining the gains that have been made to date in supporting the implementation of not just the global commitments, but the regional and national commitments as well. So we are looking forward to rallying our voice behind advocating for equitable access to antimicrobials and diagnostics. And of course, advocating for prevention first, because for a region, this really is our first line weapon. And then the point of engagement of the community is important. We have not made 100% use of engaging community. A lot of work has been at the policy level and the facility level, but there is power that lies within the people. And then to multisectoral governance from a One Health approach, and finally, working towards identifying sustainable financing for AMR action that is suitable for the region. And with that, Chair, I want to say asante sana, zikomo, siabonga kakulu, obrigada, merci beaucoup, thank you, and from where I come from, Orio Muno. Thank you.
Thank you, Evelyn, for the regional progress and recommendations. Next, I will invite member states to indicate their intention to make statements. Eswatini, you're first.
Thank you, Chairperson, Excellencies, distinguished delegates. The COVID-19 pandemic was a clear warning and a lesson in that when global supply chains are disrupted, countries can be left without essential products, such as tests, medicines, protective equipment, and vaccines. For our region, health security cannot depend only on external markets. We must build a stronger local and regional capacity to produce and secure priority health products and commodities. Local manufacturing is therefore not only an industrial ambition, it is a public health investment. It aims to enable us to sustain routine health programs, to respond faster during emergencies, to reduce costs over time, and create skilled jobs for our people, especially our youth. For Eswatini, our priority is to create an enabling environment for reliable supply and quality assured local production of medical commodities. This requires clear and predictable policies, efficient regulation that protects patients while supporting innovation, targeted skills development, and partnerships that enable technology transfer and build local know-how. It also means using financing and procurement more strategically so that local manufacturers have market certainty to invest with confidence. Honorable Chair, the Kingdom of Eswatini recently upgraded the Medicines Regulatory Unit to an authority with the mandate of regulating the registration, importation, quality monitoring, and post-market surveillance of medical commodities. This we consider to be the right step in the right direction. Regionally, we must move together and harmonize standards, establish pooled procurement where feasible, and establish stronger collaboration through SADC and other continental mechanisms that open larger markets and local production more viable and competitive. As I conclude, Chair, Eswatini welcomes the regional and global support, especially for financing, technology transfer, and regulatory strengthening to accelerate this agenda and ensure affordable, reliable access for our people. Our deliberations today should generate practical insights and clear commitments and strengthen country readiness and position the ECSA region to participate meaningfully in regional and global health product markets. I thank you, Chair. Siyabonga.
Thank you, Eswatini. Next is Uganda.
Chair, thank you very much. Just I have 3 comments. The first one on antimicrobial resistance, and it has been stated here that it is a time bomb. And the earlier we address it, the better. The antimicrobial resistance can only be mitigated if we invest more in intersectoral collaboration. The phenomenon of One Health in most of our setting is not yet strong. We see the overlaps of agriculture, the use of antibiotics, and we consume milk that has antibiotics, that has tetracycline, and we continue to experience this antimicrobial even when we have not consumed antibiotics. The second thing, Chair, is the access to medicines, antibiotics right now that can treat antimicrobial resistance. If I talk about vancomycin, I don't know how many of our people now can access this medicine. We need to encourage member states. If we still have the window of manufacturing generics, we invest in making second-line antibiotics in the country. Right now, nearly 100% are imported. And this, because this is a big issue, we request that ECSA and the member states take this as a priority. Thank you, Chair.
Thank you so much, Uganda, for your statement that lasted less than 2 minutes. Thank you so much. Tanzania.
Thank you, Chairperson. Honorable Ministers, distinguished delegates, I thank the ECSA Health Community Secretariat for convening this 76th Health Ministers Conference and for placing local manufacturing of health products at the center of our regional agenda on health security, equity, and sustainability. The COVID-19 pandemic, together with other global health emergencies, exposed a serious vulnerability across Africa due to our heavy reliance on external sources for essential health commodities. These experiences taught us a clear lesson that Africa cannot achieve sustainable health security without health product sovereignty. For Tanzania, this is not a theoretical discussion. Strengthening local manufacturing of quality-assured medicines, diagnostics, vaccines, and medical supplies is a strategic priority, firmly embedded in our national health, industrialization, and development agendas. Chairperson, in line with the resolutions of the 74th Health Ministers Conference, Tanzania has taken deliberate and practical steps to advance local manufacturing. We have strengthened our regulatory systems through the Tanzania Medicines and Medical Devices Authority, TMDA, which attained and maintained level 3 maturity for a couple of years now and is in the process to attain maturity level 4. The achievement expected to fast-track pathways for locally manufactured products. Chairperson, our local production capacity is still insufficient to meet internal demand, with 11 pharmaceuticals producing oral, liquid, and solid dosage forms ranging from painkillers, analgesics, infusion, masks, surgical and N95 to antibiotics. We also have 2 large modern industries that produce long-lasting insecticides, treated nets, which are exported to majority of Global Fund beneficiaries, as well as bed sheets and gauze. Chairperson, we also recognize that the pharmaceutical sector cannot afford slow and conventional decision-making processes. Because of its strategic importance to health, economic growth, and national security, Tanzania has established fast-track mechanisms to remove structural bottlenecks and accelerate investments. In this regard, we have operationalized a pharmaceutical investment acceleration task force to coordinate and fast-track strategic pharmaceutical investments from project appraisal to final implementation, while eliminating unnecessary bureaucratic delays. As a result, this year we will start manufacturing ARVs from June 2026. Chairperson, Tanzania fully aligns with key continental and regional frameworks, including the African Union Agenda 2063, Africa CDC's new public health order, the African Medicines Agency, and the African Medicines Regulatory Harmonization Initiatives. These platforms are essential for accelerating the approval of quality-assured locally manufactured products, strengthening regulatory reliance, and expanding regional pooled markets. Tanzania remains firmly committed to this agenda. As we deliberate during this conference, I urge us to move from policy to implementation. Let us align procurement policies, accelerate regulatory harmonization, mobilize investment, and deepen regional collaboration. The outcomes of this conference must produce measurable benefits for our people. Chairperson, the United Republic of Tanzania hereby invites all interested parties to join the partnership to achieve the African agenda for pharmaceutical manufacturing. Together, let us build a resilient, self-reliant, and equitable health future for our region and for Africa as a whole. I submit. Thank you, Siyabonga.
Siyabonga, Tanzania. I now invite questions or comments from the rest of the participants. Not more than 2. Even 0 is a good number. Yes, finally I got a 0. Thank you so much. It means the presenters and the country statements were clear. Now that marks the end of session 8. Yes. I will now invite the ECSA Secretariat to come forward to present the draft resolutions for adoption before our very last session, that is the closing session. Thank you.
Thank you, Honorable Chair, and good afternoon to the Ministers of Health, as well as representatives from the other member states for the other Ministers of Health that may not be here. I will be presenting to you the draft resolutions based on the conversations that we've had during this Health Ministers Conference, as well as the recommendations that are coming from our Directors Joint Consultative Committee, which is our technical body, and they met in August last year, and the recommendations were presented to our advisory committee, and they were actually now brought to your attention as well through the different documentations that came to the heads of delegation in preparation for this meeting. So last night we did share with the member states the different communiques that came from the pre-conferences. The first communique was the one on the youth, and which was really looking at addressing demographic dividend and sexual reproductive health. The youth had different recommendations that have been shared with you for your consideration. The second one was a communique that came from another pre-conference, which had some of the senior health officials that are sitting in here, and recommendations were drawn, and the recommendations were actually shared by a permanent secretary from Malawi within this meeting. They're also being taken in this session for your consideration. There's a communique that was shared. A printed one will be shared with you shortly. And then the final document, which is a result of this meeting, is the draft resolutions that are now showing on the screen. And I will ask the chair how we proceed with the reviewing of the draft resolutions.
You can summarize, then I'll request member states to adopt or amend that resolution.
All right, thank you. So we have a total of 10 resolutions coming from the Health Ministers Conference, and they're addressing different areas based on the themes of this particular Health Ministers Conference, the 76th Health Ministers Conference. I will take you straight to the first resolution. I will not dwell on the preamble. I will go straight to the directives to member states and the Secretariat. And the first directive is looking at reducing reliance on external financing by strengthening domestic resource mobilization for health. The second one is to enhance the role of the national budget as the primary prepaid financing pool for health towards achieving equity and financial protection. And the third is to implement strategic purchasing reforms, shifting from input-based to output and results-based financing. That is for the member states. For the Secretariat, the Secretariats are to support member states in implementing past resolutions on health financing, support harmonization of financing reforms and benefit package design, and support member states with the integration of health economics into pre-service training programs for health professionals. I submit, Chair.
Thank you. Member states, East Central Southern Africa Health Community 76, Resolution number 1, accelerating innovative health financing for sustainability in the ECSA region. Do we adopt this resolution? Any comment? Lesotho?
Lesotho proposes the adoption of the resolution.
Any second? Mauritius seconds. Thank you. Resolution number 1 adopted.
Okay. I may proceed? Okay. So we'll proceed to the second one, which is looking at progress on building capacity on health emergencies, response and resilience in the region. I will go straight to the directives to the member states. And the first is to accelerate the implementation of past resolutions. The second is to adopt and implement the pandemic agreement in alignment with national strategies and so forth. And the third is to support the establishment or strengthening of national public health institutes to enhance member states' capacity. And the fourth is to prioritize reduction of cholera case fatality and other epidemic-prone diseases. For the Secretariat, we've been asked to provide capacity building and technical assistance in cross-border health preparedness, develop and disseminate regional toolkits, case studies, and guidance documents, coordinate with global actors, including AU, Africa CDC, WHO, Commonwealth, and other RECs, in a unified, influential voice, and to the partners to align technical and operational assistance to country-led epidemic-prone diseases readiness and response plans. And the second is to support implementation research and operational learning that improves effectiveness of epidemic-prone diseases prevention, detection, and response interventions in recurrent hotspots. I submit, Chair.
Thank you, Dr. Tina. Resolution number 2, progress on building capacity on health emergencies, response and resilience in the region. Do we adopt? Do we amend? Any comment? Zimbabwe?
Thank you, Chairman. I move that we adopt the resolution.
Thank you, Zimbabwe. Any seconder? Malawi?
We second, Chair.
Resolution number 2 adopted. Thank you.
I can proceed. So we move on to the third resolution, which is promoting well-being and sexual and reproductive health of adolescents and young people to achieve demographic dividend in the East, Central, and Southern Africa Health Community region. We'll go straight to the recommendations for member states to accelerate implementation of past resolutions, institutionalize intersectoral collaboration among ministries of health, education, youth, and labor to develop and implement strategies addressing the social, economic, and psychosocial determinants. The third, to review and update relevant legislation, policies, and strategies to incorporate youth-specific interventions. And the fourth, to establish and expand youth-friendly services. And to the Secretariat, to establish a formal regional youth advisory platform. The second is to enhance regional accountability framework to track progress on health and well-being of adolescents and young people. The third is to support member states in adopting and operationalizing the regional mental health framework. I submit, Chair. I think that's the last one. me just check. Yes.
Thank you, Dr. Tina. Resolution number 3, promoting well-being and sexual and reproductive health of adolescents and young people to achieve demographic dividend in the ECSA health community region. Member states, do we adopt? Uganda?
Support the resolution.
Any seconder? Tanzania? Resolution number 3 adopted.
Can proceed. Thank you. So we move on to the 4th resolution, which is strengthening regional health data integration, interoperability, and digital governance in the ECSA region. We go straight to some of the recommendations, which is 1, to accelerate the implementation of past resolutions, to adopt and implement regional interoperability standards, and the 3rd, to establish or strengthen data governance and cybersecurity, and the 4th, build capacity and strengthen data to action practices, and to the Secretariat to share lessons learned, best practices and technical expertise, to provide technical support to member states to reduce fragmentation and establish a regional health data repository. And to the 4th one is to track and report progress on implementation of this resolution. I submit, Chair.
Thank you, Dr. Tina. Member states, resolution number 4, strengthening regional health data integration, interoperability, and digital governance in the ECSA region. Do we adopt? Malawi?
Thank you, Chair. Malawi proposes to adopt the resolution.
Thank you, Malawi. Uganda?
I wanted to propose resolution number 2 for the member states, because we are at a different level of development of the digital systems. When we start giving this resolution as something, I think we may not achieve this, because we need, first of all, to ask member states to strengthen the digital systems within the country, because you find that different countries are at different levels. So when we talk about interoperability right now, when the systems in the countries are still shaky, they are not well established, we will not be able to achieve this recommendation until we have first strengthened in the country digital systems. So I think that we need to revise that. Thank you.
Any suggestions how to strengthen that one from member states?
So, Chair, I beg your indulgence. Maybe we can come up with some language that we can share with the member states at the end.
Okay, let's say that would be taken care of by Secretariat to strengthen it. But in principle, do we adopt?
With the correction, yes.
Any seconder? Malawi moved for adoption. Tanzania? Thank you. Resolution number 4, strengthening regional health data integration, interoperability, and digital governance in ECSA region. Adopted with amendments. Thank you.
Thank you. Can proceed? Okay. So we move on to the next resolution, which is on tackling non-communicable diseases. This resolution has got recommendations to the member states to accelerate implementation of past and current resolutions on non-communicable diseases, including sin taxes, tobacco, alcohol control, and food safety. develop and strengthen comprehensive frameworks that are gender and marginalized populations inclusive, institutionalize disability across the life course, strengthen multi-sectoral engagement, including supply chain systems monitoring, adding important mental health medications on the essential medicines list. The second, to the Secretariat, is to promote digital innovation and integration to strengthen monitoring, evaluation, and real-time feedback systems for non-communicable diseases, document and scale up best practices on disability prevention and rehabilitation, and support countries to integrate disability, musculoskeletal, and rehabilitation services into existing health policies. And to our partners to collaborate on digital platform innovations, to improve NCD service delivery, and to provide targeted technical and financial resources to support the Secretariat and Member States. I submit, Chair.
Thank you. Resolution number 5, tackling non-communicable diseases. Do we adopt? Uganda?
I suggest resolution number 3 to member states. We include geriatric services, geriatric care, because we discussed it, but it's not captured.
Okay, that's noted.
Any country moving for adoption after that amendment or addition? Mauritius?
Yes, Chair, I recommend that we adopt the resolution with the amendment proposed. Thank you.
Thank you. Any seconder? Zimbabwe? Thank you. Resolution number 5, tackling non-communicable diseases, approved with amendments. Thank you.
Okay, thank you, Chair. Move on to resolution number 6, enhancing leadership, governance, and human resources for health. We have specific recommendations for member states. The first is to accelerate the implementation of past resolutions on human resources for health, support cross-country learning and south-to-south collaboration to bring scalable changes, harmonize regional qualifications by developing a regional framework, that standardized training programs, incorporate innovative training models to enhance practical skills building and incorporate soft skills training programs for health workers. And the fifth is having strategic planning for health workforce training, taking into consideration absorption as well as quality of those that are being trained and upscaling of the wider health workforce. To Secretariat to provide technical support and capacity building in the implementation of the above and monitor implementation of past resolutions, and to our partners to support professional development initiatives such as fellowships programs, leadership training, etc. Partner with governments to develop digital learning platforms. I submit, Chair.
Thank you. Resolution number 6, enhancing leadership, governance, and human resources for health. Do we adopt? Zambia?
Thank you, Chair. Zambia proposes we adopt the resolution.
Thank you, Zambia. And seconder? Uganda?
I second the resolutions.
Resolution number 6 adopted. Thank you.
Okay. Thank you so much, Chair. I proceed to number 7, progress in responding to communicable diseases and NTDs in the ECSA-HC region. The recommendations to member states are strengthen and sustain laboratory systems by increasing domestic investment in diagnostic infrastructure, equipment maintenance, quality management systems, and accreditation. The second is to leverage regional reference laboratories and networks for learning, mentorship, external quality assurance, and proficiency testing. And the third is to integrate communicable diseases and NTD services into primary healthcare, including surveillance, diagnostics, treatment, and referral systems. And the fourth is to accelerate implementation of past resolutions. To the Secretariat to facilitate regional coordination and knowledge exchange on laboratory system strengthening, communicable disease control, and NTD elimination through structured platforms, provide technical support to member states on laboratory accreditation, and to report on the implementation of this and past resolutions to the 78th Health Ministers' Conference. To the partners to collaborate with member states in strengthening laboratory systems and to support implementation of integrated prevention-oriented approaches to communicable diseases and NTDs. I submit, Chair.
Thank you. Resolution number 7, progress in responding to communicable diseases and NTDs in the ECSA region. Member states do we adopt? Zambia?
Zambia agrees with the resolution and we propose to adopt it, except the directs to the Secretariat, Statement 3. It says resolution to the 78th Health Ministers' Conference. Is it not supposed to be 77th?
I can proceed to respond. Thank you for that inquiry from Zambia. So it's the 78th Health Ministers' Conference because we have a more closed Health Ministers' Conference that is held alongside the World Health Assembly, which will be our 77th, and that's going to be in May. But most of these recommendations come from the Directors' Joint Consultative Committee, which will be held in August, and then with whatever recommendations they'll come up with, they'll be then presented in the next year in the 78th.
Okay. Any seconder for adoption?
Chair, I'm sorry to take you back. I think this section we needed to have a resolution on cross-border MOUs to especially on malaria and other communicable diseases.
Chair, it's been noted and we will revise for the final adoption.
Thank you, Uganda, for that. It will be taken care of. Any seconder for adoption after that amendment?
Seconded.
Thank you, Lesotho. Resolution number 7 adopted with amendments. Thank you.
Okay, permission to proceed. So we move on to the next resolution, which is Resolution 8, Driving Innovation and Resilience, Local Manufacturing for Health Security. We have a number of recommendations for the member states. The first is to advance local manufacturing agenda to improve equitable access to medicines, diagnostic vaccines, and health technologies, which has a number of specific areas for the member states, which include a regional collaboration mechanism, investing in fit-for-purpose workforce development, negotiating and embed technology transfer provisions, and establish market guarantees through instruments. The second recommendation is to prioritize integration of priority AMR interventions into national health and One Health budgets. The third recommendation is to establish a national parliamentary platform or network on AMR and to accelerate implementation of past resolutions. To the Secretariat to advocate for policy, regulatory, and long-term financial reforms, to convene member states and partners to develop and table the ECSA-HC regional position on AMR, and to facilitate the establishment and operationalization of the regional parliamentary platform on AMR, and coordinate regional collaboration and foster multidisciplinary partnerships. To the partners to support member states and the Secretariat with the necessary technical and financial resources to accelerate the implementation of the above resolution. I submit, Chair.
Thank you. Resolution number 8, Driving Innovation and Resilience, Local Manufacturing for Health Security. Do we adopt this resolution? Tanzania?
Thank you, Chair. Tanzania proposed to adopt the recommendation, but with some amendment, we have to add the counterfeit medicine management. We propose that. Yeah.
Okay. Chair, that is noted.
Anyone with an opposing view? No. Any seconder for adoption after that amendment? Zambia?
Zambia seconds.
Thank you. Resolution number 8 has been adopted with amendments.
Chair, the last two resolutions, the first, which is resolution number 9, is to express gratitude to our partners of the ECSA Health community, and resolution number 10 is to express our gratitude to the government and the people of the Kingdom of Eswatini. I submit.
Thank you. Anyone with an opposing view? Anyways, we need your blessings to adopt these resolutions. Do we adopt resolution number 9 and number 10? Okay. I will assume the clap of hands means we adopt. Yes. And Malawi wanted to second. Yes.
So, Chair, maybe to beg your indulgence, if there are any comments on the communiques that we shared, maybe we can also get those comments because those are the annexes to these resolutions.
Thank you. Noted. Any comment? Going once, going twice? Gone. Thank you, our wonderful presenter, Dr. Tina. Resolution number 1, 2, 3, 9 and 10 adopted with no amendment. And resolution number 4, 5, 6, 7, 8 adopted with amendments. And that marks the end of our session. You can clap for the chairperson. Thank you so much. Now we will move to our last session, which is the closing ceremony, and it will be directed by the PS Health in Eswatini. Please come forward, PS.
Honourable Minister, let me rally behind all protocols because of time. It is now my singular honor to say we have come to the last item in our very packed agenda. My task is simple, is to ensure that we follow the agenda as articulated here. So for first presenter or remarks, comments, we'll request Dr. Dooley Kapolongwe, the Director General of the ECSA-HC, to come and make his remarks. Can we give him a round of applause, please?
Thank you very much, Program Director. Honorable Nduduzi Masebula, Member of Parliament, Minister of Health, Kingdom of Eswatini, and the Chairperson of our 76th Health Ministers Conference, Honorable Madalisto Balori, Member of Parliament, Minister of Health and Sanitation from the Republic of Malawi, and an outgoing chair of 76th Ministers Conference, Honorable Ministers of Health here present, Mr. Mawa, Permanent Secretary, Minister of Health, Republic of Mauritius and Chair of the Advisory Committee, Permanent and Principal Secretaries present, Dr. Atanas Meikyo, the Director General of West Africa Health Organization, WOW, Dr. Deo Mapinga, the Secretary General of Forum of Parliaments of the Great Lake Regions, my brother Linton, on behalf of the Director of Human Capital from the AUDA, NEPAD, Caroline from Lado Global Health, Dr. Liu Riek from Africa CDC, representing the Director General of Africa CDC, Dr. Lucy Mazianga, Director for Africa CDC, representing the Eastern Region, Dr. Ahmed Aguero, the CEO and the President of the Village Reach. We have Professor Juk from the Swiss Tropical and Public Health Institute, distinguished partners, colleagues, ladies and gentlemen, good afternoon. Bonjour, Madame, Monsieur. Bonjour. Bon dia. San Bonan. Your Excellency, Chairperson of the 76th Health Ministers Conference, as we come close to the 76th Health Ministers Conference, allow me to express my profound appreciation to all of you for the exceptional leadership, commitment, and solidarity demonstrated over these past days. I extend my sincere gratitude to the people and the government of the Kingdom of Eswatini for the warm reception and unwavering support accorded to us from the first ever Youth Summit on Sexual Reproductive Health and Demographic Dividend to the Health Financing Dialogue on Value for Money, Value for Health, and the critical discussion on antimicrobial resistance. Your hospitality created not just welcoming environment, but a fertile ground for the meaningful dialogue and collective action. Your Excellency, I wish to convey special thanks to you, the Chairperson of 76th Health Ministers Conference, and your entire ministerial team for your exemplary leadership and close cooperation that you gave the team from the ECSA Health community. Your guidance and partnership with the ECSA Health community Secretariat were instrumental to the successful delivery of all these engagements. Allow me to thank you most sincerely for the wonderful dinner we shared yesterday, accompanied with excellent entertainment and the beautiful gifts that were graciously presented to us. We are deeply grateful for your generosity and warm hospitality. Honorable Chair, I must say that in our yesterday's dinner event, I gotten to learn that majority of ministers of health from the ex-health community are the great dancers. Thank you very much. Your Excellency, the conference has been marked not only by high-level presence, but a high-level purpose. It brought together more than 360 participants from more than 20 African countries, as well as representatives from continent Europe, Asia, and Americas, united by the shared resolve to strengthen health systems and advance the health and well-being of our people. Above all, this gathering has reaffirmed a simple but powerful truth. When we come together with clarity of purpose and unity of action, we move from dialogue to decisions, from commitments to concrete results, and from ambition to impact. Your sustained engagement has added depth, continuity, and credibility to our collective work. Your Excellencies, this conference has taken place at the defining moment of our region and for the global health under the theme Enhancing Health System for Equity, Resilience, and Sustainability. We moved decisively beyond reflection to action. We engaged in a frank dialogue, grounded our discussion in evidence, and reaffirmed our shared responsibilities to protect and advance the health of our people. Over these days, we have seen the regional leadership, regional solidarity, regional sovereignty, regional diplomacy in action truly looks like. Ministers and delegations shared their experiences openly, confronted difficult realities, and agreed on the clear way forward. The resolutions adopted just now are not abstract declarations. They are practical commitments anchored in our country's realities and regional solidarity. And let me take this opportunity, Your Excellencies, to promise you that under my leadership, ECSA will make sure that these resolutions that have been passed or adopted here are implemented accordingly. I commend you, honorable ministers, for the clarity and direction that you provided to us. Your guidance strengthened our mandate to coordinate, to convene, and support implementation, ensuring that decision that has been taken here, they won't be remaining in this room. Rather, they will be implemented in our respective countries. Ladies and gentlemen, the conference has reaffirmed the fundamental truth. Regional cooperation is no longer optional. It is essential. The deepening engagement with sister regional bodies like WAHO, IGAD, that is the true testament how the cooperation and how the mobilization of resources should look like. Your Excellency, as we depart from the kingdom of Eswatini, which majority of them and majority of us, of course, say it's a beautiful kingdom, our task is clear. The true value of this conference will not be measured by quality of our dialogue alone, but by decisiveness of our follow-through. Looking into the key words that are making up our theme, equity must be reflected in who accesses services, not just who speaks in the police rooms. Resilience must be visible in our preparedness, response, and recovery. Sustainability must be secured through smart financing, strong institutions, and a protected, motivated workforce. The Secretariat stands ready to work closely with all member states to support implementation, track progress, and strengthen accountability. But not only the member state, with all our esteemed partners who are here in today. We are banking on you. Our trust on you is quite very high, and we believe together we can make our continent healthier. History will be remembered, and history also remember this gathering, not for just its value, but for its resolve. Let it be said that 76th Health Ministers Conference, our region chose cooperation over fragmentation, long-term vision over short-term fixes, and action over hesitation. Let it be said that we did not meet to manage crisis, but to shape the future of health in East, Central, and Southern Africa. As we to carry forward the spirit of unity, courage, and shared responsibility that has guided our deliberations. Confident and together, we can build systems that can serve not only today's needs, but tomorrow's generations. Your Excellencies, I would be remiss if I did not sincerely acknowledge the many partners, institutions, and friends from across the globe who have worked with us on this journey. Your technical expertise, political support, and resource mobilization reinforce a simple but powerful truth. No single country, no single institution can build resilient healthcare system alone. Appeal to you, our esteemed members, appeal to you, our esteemed partners. Join us in the implementation of resolutions. And these resolutions are implementable, they are smart. Together, we can successfully implement them. Finally, allow me to once again extend our deepest gratitude to the government and the people of the Kingdom of Eswatini. The hospitality, professionalism, and commitment demonstrated throughout this conference has been exceptional. Eswatini has not merely hosted us, it has inspired us. From the seamless organization to the spirit of Ubuntu that defined our interaction, this conference will stand as a benchmark for the regional cooperation. Let us return home, not just informed, but resolved, not just united, but accountable, and not just hopeful, but decisive. God bless you. Thank you very much. Muito obrigado. Merci beaucoup. Asante sana. Zikomo kwa mbili. Siabonga kakulu.
Thanks, Doc. I think the other profession, a linguist, can tell that you have captured almost all the languages of the region. Thank you so much for the remarks and the statement. At this point, ladies and gentlemen, allow me to request the chairperson of the ECSA Advisory Committee and also the permanent secretary of the Ministry of Health in Mauritius, the chairperson, Pamanata Mawaha, to come over and make his remarks. Over to you. Thank you. Can you give me one?
I don't know what to say because the Director General has said all. Honorable Masabula, MP, Minister of Health, Kingdom of Eswatini, and Chairperson of the Health Ministers Conference, Dr. Kapulogwe, Director General of ECSA Health Community, Excellencies, Honorable Ministers, dear colleagues, partners, ladies and gentlemen. Good afternoon. I wish to thank you all for having participated in the deliberation of this conference and shared your experiences and insights into the burning health issues affecting our people and to make efforts towards identifying equitable, well-balanced and sustainable solutions. As chairperson of the advisory committee, I wish to place on record the unflinching support of the members of the committee, their dedication in fulfilling our mandate. Your contribution during our deliberations have enabled us to reach decisions for the furtherance of the objectives of the ECSA Health community. I am also thankful to the honorable ministers, particularly the outgoing chairperson of the Health Conference, Mrs. Baloi, Minister of Health of Malawi, for the consideration and guidance on matters of critical importance to the Advisory Committee. I am also grateful to the Director General and all staff of the ECSA Health Community Secretariat for having provided us with all the necessary support in carrying out our mandate in the best possible way. Ladies and gentlemen, let me take this opportunity to make a humble request to the chairperson to convey to His Majesty, the King of Eswatini, for having graciously allowed us to have an audience with him. This was a unique opportunity for us. And for His Majesty to have shared with us his concerns on the issue of health and well-being of the people of not only the Kingdom of Eswatini, but of the whole African continent. His words and advice were indeed inspiring and motivational. I would also make a request to the chairperson to convey our thanks to the Honorable Deputy Prime Minister of the Kingdom of Eswatini for having been the chief guest for the official opening of the present Health Ministers Conference. I wish also to thank the Ministry of Health of the Kingdom of Eswatini for having graciously hosted this conference. A special thanks to our friend and colleague, Principal Secretary Mr. Mabuza and the members of his organizing team for the excellent organization of this conference. Last but not the least, our deep appreciation to Honorable Matsebula, MP, Minister of Health, Kingdom of Eswatini, and new chairperson of the Health Ministers Conference. Congratulations on your appointment as a new chairperson, Minister. I am confident that under your leadership and guidance, we will fulfill our responsibilities in the best possible way. We are very confident that under your leadership, ECSA Health Community will continue to strive and flourish and work towards the betterment of the lives of our citizens. Thank you for your attention.
Thank you, Mr. Maha, for the remarks and the encouragement. We feel rejuvenated, and you can tell now I'm getting more brighter. When we were preparing for this meeting, the first day I was more darker. And to appreciate the work that has been done, we really don't take that for granted. Ladies and gentlemen, at this point in time, it's my singular honor and pleasure for the first time to introduce my minister, not only as a minister, but as a chairperson of ECSA. So if he's becoming a chairperson, it means I'm also a vice chairperson, isn't it? It is a great pleasure, Honourable Minister, MP, Minister Mutuduzi Matsebula, who's the Minister of Health here in the Kingdom of Eswatini, for this assembly to welcome you, to make a statement. I almost said maiden statement. I corrected myself, not maiden statement now, but a statement marking the closure of this session. So, ladies and gentlemen, please join me and welcome the Honourable Minister as he takes the podium by raising up and allow him to take the podium. Please do raise up.
Thank you. We may be seated. Thank you, Program Director and Deputy Chair. Honorable Ministers, members of parliament present here, distinguished delegates, DG, directors, esteemed partners, ladies and gentlemen, all protocol observed, good afternoon. We gather here at the closing of the 76th session of the Health Ministers' Conference. I wish to express my sincerest gratitude to each of you for your contributions. Your active participation, insightful contributions, and unwavering commitment have formed the very foundation of our fruitful discussions over the past days. Throughout our time together, we have tackled some of the most pressing health challenges of our time. We appreciate hosting the first ever ECSA Regional Youth Summit with the theme on sexual reproductive health and demographic dividend. During this summit, the youth made it clear that they should be included in decisions pertaining sexual reproductive health. And they said they don't want to be just followers, but leaders, and we should make the environment conducive for them to lead. I implore our member states to make this wish a reality going forward. During the ECSA Health Ministers meeting, we explored critical issues such as sustainable health financing, which is essential for long-term sustainability and growth in our health system. We have discussed the importance of transformative partnerships in research and data governance, which are vital for advancing health innovation and ensuring that data is used effectively for public health. Our dialogue emphasized health security, particularly in the context of antimicrobial resistance, a growing global threat that requires our immediate attention. In addition, we addressed the pressing need for strengthening our human resources for health, recognizing that dedicated and adequately supported professionals are the backbone of any health system. We also committed ourselves to the fight against neglected tropical diseases, which disproportionately affect vulnerable populations and demand our urgent action. The resolutions we have endorsed today are a testament to the collective effort and collaboration that has taken place within this conference. Now, as we move forward, it is crucial that we take the next steps with intention and vigor. I urge every country and partner to proceed purposefully from the resolutions we have crafted towards their implementation. This means that these commitments must not remain as mere statements. They should be translated into actionable national action plans that are specific, measurable, and time-bound. Monitoring our progress will be key. We must establish robust mechanisms for tracking our implementation efforts and ensure that we report our achievements and challenges regularly and transparently. By committing to this cycle of implementation, monitoring, and reporting, we hold ourselves accountable and enhance our ability to achieve meaningful public health outcomes. Let us continue to work closely together, fostering innovation and collaboration as we seek to overcome the obstacles that lie ahead. The time for empty rhetoric has passed. We are now entering an era defined by actionable collaboration and tangible results. Looking ahead, I'm delighted to invite you to partake in the ECSA Health Community Best Practices Forum this August. This platform will provide us with an opportunity to share our experiences, showcase early progress, and highlight successful resolutions that can be leveraged across our nations. For those who have the opportunity to stay longer, I encourage you to explore the diverse and beautiful wonders of our kingdom. This is a chance to experience the rich culture and hospitality that our country has to offer. As you prepare to depart, I wish each of you a safe and pleasant travel home. May you return filled with renewed determination and enthusiasm to foster a healthier, more secure future for all our citizens. Siyabonga, nihambe kahle. Thank you and farewell.
Thank you so much, Honorable Minister, for the remarks. I have few announcements. Please do listen very attentively. And want to apologize for confusion when it comes to issues of lunch. I think yesterday it wasn't. So we request that we follow this sequence. So lunch for our VIPs will be at the Fine Restaurant. They will show you where the restaurant is by the door side. So you will not get the coupons by this door side. So you'll get the coupons by the restaurant door. That's where the VIPs are going to get the coupons. Let me repeat myself. For VIPs, we'll ask all the chauffeurs who are around to escort them to the Fine Restaurant. Coupons, we are going to get them by the door side. So we'll allow them to leave the room first. So the coupons for us, all delegates, as you leave this hall, they'll be served by the desk sites where we registered. So before you leave, do make sure that we have your white coupon. It helps us for reconciliation purposes. So I'll request that we follow that sequence. So for tomorrow, delegates who are leaving tomorrow, please, delegates are requested to be at the hotel reception, but the reception, the foyer, if you are staying in this hotel. But if you're not, please, you can talk to the people who are escorting you to actually ensure that you leave this place, or Zolini, if you're around Zolini. The latest is 2 hours before your schedule of the flight. But for those who are staying in this hotel, delegates are also requested to go to the reception area 2 hours before your flight departure. Please keep time. Report to the reception at this hotel if you are staying here 2 hours before departure of your flight. They will want to arrange transport. It takes about 1 hour or so to reach the airport, but you must be there 2 hours, checking out time 2 hours, and you register for the transport to the hotel. And for the afternoon, we have the code here. For those who will be interested to visit the places that we mentioned earlier on, the team requests that you remain behind for a few minutes so that we can work on the logistics and to ensure that we have transport to the areas that we're going to visit. As indicated, we've got 2 sites. There is a site in Manzini. Manzini is a commercial hub for Eswatini, We have a clinic called HF, which is working primarily on issues of HIV, TB, and it's a place where we introduce the lab Capavira there. So if you want to say anything to do with HIV and the land, I'll encourage you to visit the clinic. It's not only a visit to see the clinic. Like I've said, Manzini is a commercial hub. So there's a market there in Manzini. It has all domestic wares, even the colors that you were wearing or got yesterday. If you want more, I'm promoting that you utilize Manzini Market. They must give me commission for this. The reason is it's comparatively cheaper than buying outside that market. If you go to the private stores, you may find that you are probably picking up by 30% more. So if you want to get any Swazi souvenir, I will encourage for those who go to the HF, to the clinic, it will give you time to go to the market. It's a busy market, but I've been assured that there will be security for all of you. To Manzini, it's about 30 Ks, so it's not that long. For those who want to go to Ngwenya, which is a local design manufacturer for eco-friendly classes, Ngwenya is about 35 kilometers from here. You go past Mbabane, but I'll encourage you to also go to Ngwenya. For those who have passed different airports, you'll find their classes said made in Ngwenya, made in Ngwenya. Minister, I did my calculation. I will not mention the airport, hence they may take me to task. I found that glass there. I think it was a mimic of an elephant. It was about 200% more than the price that you'll pay over there. So if you want anything to do with glass, eco glass, they can actually mold it for anything.